per 1,000, and the more lighter one, which represent about 10.6 or 24.4 case per 1,000. Okay, so still we have a sizable ratio should be considered in the our region for diagnosis. And prostate cancer have a special features because there are many patients could have a prostate cancer and they don't know, and even their doctors doesn't know, okay? And they may live a normal life, no problem at all, and can die from any other causes. Why? Because prostate cancer has two extremes. That is what we call the significant or non-significant prostate cancer. So the question is in our mind for the doctor and for the patient, if the patient has a prostate cancer, the question is it significant or not significant? The not significant, it means what we call indolent cancer. It means that this cancer is not a killer cancer. The patient can survive without any management, without any intervention, just for follow-up. Just the patient will be under surveillance, okay? So this indolent type is not our interest, but our interest is the significant one. We look for the ratio of the indolent, it represents for almost 40% of the cases. So it is a sizable ratio, it's a significant ratio of this cancer. So we have about 60% of the patients, we have prostate cancer. And this is a big problem along the literature of the prostate cancer because before the year 2012, all the Western countries and USA make a very expensive cost to diagnose cancer. A lot of resources spent for diagnose just the prostate cancer. And they found that it's not all prostate cancer need to be treated. So they make a very huge fund, endless funds, without no need, without need to spend this. From this, they try to discover a tool to determine, to make a risk stratification, can stratify between the significant cancer and indolent cancer. This is their main focus in this era. So the classic diagnosis for prostate cancer before 2012, it's like this, as you see. If you have a suspicious arising PSA, you have a suspicious DRE, digital rectal examination. So ask for transrectal ultrasonography, and if there is a positive, so you have a prostate cancer. Okay, so prostate cancer, the pathologist will determine which type it is significant or not significant based on what we call the Gleason score. We will talk about it later, okay? So this is the classic diagnosis before 2012, okay? PSA is a hormone released from the prostate, but we'll see later it's not a specific, but it is sensitive because it can rise for many reasons, okay? The percentage of this approach not exceed 50% to discover or diagnose significant cancer. This means that 50% of significant cancer were lost. At the same time, this 50% include the indolent cancer itself. So the detection of the significant cancer is much lower than 50%. So in this era, we lost many cases of prostate cancer, and usually the first presentation of these patients was end stage, advanced stage with metastasis, and so it's considered this era the first man killer in the Western cancers. So they need to modify this approach by searching for another tools. These dates, 2012, 2015, 2019, are crucial dates for development of another tool, what we call now the multiparametric MRI. All these association, you can notice that this is the European Society of Urogenital Radiology, this is the American College of Radiology, and this is the AdMedTech Foundation. All these USA foundation, except the European Society, this is the official European Organization of Urogenital Imaging, spend a lot of money and they make multiple committee and MDT between the urologist and radiologist, the oncologist and histopathologist to try to develop a new tool to modify the current approach, okay? In 2012, the European Society of Urogenital made the first trial of what we call the PIRAT system and released the version 1, PIRAT version 1. After modification, after 3 years, 2015, American College of Radiology and AdMedTech with ESUR, what we call European Society of Urogenital Radiology, after they found that the first trial of PIRAT could be effective and could be the missing tool which they're looking for, they make a development of this system and released PIRAT version 2 in 2015. After 4 years, version 2 modified have a little modification and established another version, not another new version, but it's called version 2.1, not version 3. Version 3 is still not have sufficient data to develop yet. So we have version 1 in 2012, version 2 2015, and 2.1 in 2019. And all the reporting and all the standard reporting and diagnosis should be follow the last version of 2.1, 2019. This is an idea about the importance of the PIRAT and how it develops and why they try to develop, because the problem which established since long time. So what's the current situations? We have two problems here. We have a problem regarding urologist minds, and radiologist training. Urologist minds, as I discuss with you earlier, try to put MRI in their diagnostic approach, try to change their approach for the urologist to make MRI just before biopsy, because the routine is suspicious PSA or DRA transformed to biopsy. No, this is now obsolete, and this is now considered a medical legal issue in the Western countries, especially if the patient diagnosed with a cancer or missed cancer, so you are in a problem. So MRI should be before the biopsy. Why? Because MRI will target the urologist or radiologist, whoever take the biopsy, which area and which site you will focus and take the biopsy. Because transrectal ultrasound is a blind technique. It's a randomly. We go to the prostate, we look at the prostate by transrectal ultrasound. In most of the cases, it will be almost like normal or have some prostatitis. We cannot diagnose a suspicious focus, and we'll give all 6 core. Now we recommend 12 cores, okay, to try to cover most of the prostate. However, we have a focus 2 milli, 3 milli. It's easily to miss, as long as you know. You don't know where is it exactly. So this is the rule of MRI. MRI is like a GPS. It's like your map, your guide. Tell you from where you will take the biopsy. Okay? This is very important. Regarding this problem, okay, I think in the Western countries overcome in the last 10 years this problem and became a standard. Still in our area, I'm talking about Egypt at least, still we have a problem regarding this, especially all the urologists, they have persistence, no, they have the old system, okay, but we would try. The other problem is radiologist training. Radiologist training for how to interpret accurately and know the rules of the pyramiding system, how to perform the MRI examination from start, from the level of the technique till the level of diagnosis. These need much experience and much training. So this is the old pathway for the urologist, PSA, DRE, and TRUS. Now, this is the recent pathway, PSA, DRE, MRI, before biopsy, before TRUS. Okay? In 2016, UK now increased from 55% to 80% 2018. This approach became applied. Radiologist training, this is what we will start now. One of the radiologists, one of our training sessions for the radiologist. Okay, this is just an introduction for the concept of the prostate cancer, what's the importance, and what's the modification should know, and the importance of the PIRAT system. The second lecture, I'd like to talk about clinical concepts, especially, don't know, for radiologists, because it's very important. I think these points may be obvious for you as a clinician, for urologist, but it's very important for the radiologist to know, because this is a very crucial in diagnosis and reporting and taking. Okay. Good morning. So, always I'm saying that we are doctors. I'm talking about the radiologists. We are doctors, not imagers. Okay, we are dealing with images, but we need to know clinical concepts. It's very important from the history of the patient and clinical data, including their lab history. Important items is very important. So what I need as a radiologist to know from the patient and the clinical concept, and I think we have urologist colleagues maybe like to add some points. It will be benefit of us, okay? So I feel today we have 5 or 6 urologists, so we are in MDT meeting for prostate cancer, so I think it will be very useful for all of us. So, 3 clinical questions or items you should be know about your patient, okay? First, prostate-specific antigen, PSA, what's its level? Second, what we call prostate density. Third, what we call Gleason score. Okay, PSA is a hormone released from a prostate, okay? But as we know, it's not a specific for cancer. It is a sensitive for prostate pathology, prostate problem. It can be raised after digital rectal examination. It can rise after insertion urinary catheter, okay, prostatitis. So it has many reasons to rise the PSA. But one of the most concern of us is the cancer, okay? So it's very important before to perform MRI, to have a PSA value for your patient. Why? Because we need to calculate what we call prostate density. And the prostate density, it has an equation relying on the PSA. And PS density, it is a value you should report it in your MRI report. So the MRI report, you will not say just PIRAD, which category or final score, but in case you need to comment about the prostate density. Why? Because prostate density may be one of the solving tool in some equivocal cases. Because in every system in the human body, you know, there is a lot of PIRAD system, and in each system we have a gray zone. In the breast, in the liver, in the prostate, thyroid, we have always equivocal area or equivocal zone. So PSA density may help us in the equivocal zone or gray area of the prostate. Gleason score, it is a pathology results when you have a suspicion of patient. So it's a rule of the pathology, okay? So it's not your rule, but this is what you're waiting for. After taking biopsy, you need to know which Gleason. So if you have a previous patient with a previous biopsy, so you should ask about what's the previous Gleason score. Because in some cases, the decision management will be the patient should be followed up under surveillance, especially if you want, say, 6, Gleason score 6 or less, so it means that the patient shouldn't need active intervention, just under surveillance. It's follow-up. So it's very important for you to know what about the Gleason score too. I will give you a hint, a little hint, about each item. PSA, it's represented by nanogram per millimeter. In normal, it's up to 4. Up to 4. It means that doesn't mean if you 1 to 4, you don't have a cancer. No. We see many cases with a very low PSA and have a cancer. Okay? So PSA is not specific, as I said, but it's sensitive because most of the time, when you refer the patient for the next step, the guidance is PSA. This is what I talked about in the first lecture when we say we need searching for another tool. The PSA was the primary tool for screening. It was started from screening program in 2008, not recommended after that, and become tailored for every case scenario in 2018. So it means that PSA is a function of a patient scenario. Okay, we need it for every patient, but it's not a judgment to have a cancer or to transfer to the next step. Okay, this. So it's not specific. However, as the upper normal, it's 4 nanogram per millimeter. And as I have said, it means that if you have another suspicious example, digital rectal examination or resistant prostatitis doesn't have a treatment, you can have a suspicious of prostate cancer and you can shift to the MRI. PSA density is very important to make a judgment, as I have said in the equivocal cases. You take active surveillance or the patient need management. This is the formula to calculate the PSA density, just PSA level divided by prostate volume. So the prostate volume will be calculated from the MRI study. Okay, so it's easy to calculate the volume from the prostate MRI, but you need to PSA level, before MRI study to calculate the density. So it's very important to mention in your report the PSA level and PSA density. Okay, it's normal. Most of the literature equals 0.15, and in some literature 0.20. I don't know what you recommend as urologist, or what's the cutoff working with it.
Some papers went to 0.12.
0.12. Oh, okay. Yes.
And actually, we were using it with other methods like PSA velocity, protein. There was ways to enhance the sensitivity of PSA since long time.
Yeah. But
so density is one of them, and it's very important. Why? Because sometimes it claims that the PSA is 5 or 6.
Yes.
Having a big volume. So sometimes just reassure the patient and follow up the progress of PSA. If it's even sometimes it's not provided that the DRE is normal.
Yes. This is what we call in the equivocal case, because in the equivocal PIRAD, which usually we call it PIRAD 3, it's a decision of MDT. Okay, it's not a radiology decision or urologist decision. It's an MDT, and mostly all these data, especially from urologists, yes, I don't have suspicious DRE. I don't have a significant rising of PSA. We can make a chance for the patient to treat it as a prostatitis and see if the PSA level will decrease and symptoms will relieve. So in these cases, but in sometimes if PSAD high enough, above 0.15, and in Egypt, yes, we're working with this is cutoff value, 0.15, we can transfer for the biopsy. Okay, if reached to 0.2, in Egypt, we usually make a biopsy, even if there are no suspicion for other causes. So this is very important to know these data about. Okay, this is important. This is a screen capture from the manual of the American College of Radiology, because I found that many radiologists determine the prostate volume in a wrong way, which is very important, as we know now, to calculate the right PSA density. Okay. I found many radiologists. This is the axial, what we call the axial image, and this is, we call it the sagittal image, okay? It's wrong to take 2 dimensions in the axial, okay? But it should be like that. You will take the transverse diameter from the axial image only, and take the another 2 dimensions, which is longitudinal diameter, represented by yellow line, and the AB diameter by the blue line. So keep this in mind. This is a very important and will change the value of the prostate volume. And of course will affect your PSA density, and it will affect your decision too. So it's very important. This is a capture. We have what we call the SCR manual. Try to look at it. It's very informative. And you will find this is one of the standard way to measure the prostate volume. Okay? This is very important. Again, this is another image in the axial and sagittal image, how to measure the prostate volume. So, Gleason analysis. So, I don't need to go in depth by the Gleason concept, but what I need to know is a Gleason score. We have a Gleason grade, we have a Gleason group, we have a Gleason score. So let us discuss with the simplest pathway with the Gleason score. If we look at the middle column, like here, this is what we call a Gleason score. If we can see this, we have a cutoff value when say significant cancer. Now we understand that we are looking for significant cancer. And significant cancer is the final decision of the pathology. When I can say this is a significant cancer, if I found that the Gleason score starting from 7, above any rung, 7 or more. If we found 6 or less, so it is what we call in the first lecture, indolent cancer, and just need active surveillance. Active surveillance, the patient will need follow-up. So the question is, if the indolent cancer can turn into significant cancer? Good, of course, yes. That is why we say that we need active surveillance. We need a short active surveillance. Just in the most of the cases, it will be by PSA, not by MRI, okay? But when you have a suspicious, either by digital rectal examination or by PSA, so you will find that, oh, I need to repeat the MRI. I need to check what if there is another lesion present or not. Because you should know that in most of the occasion, Gleason score 6, it usually will bring PIRATS 1 or 2. It means that normal prostate. So the significant and the magnificent rule of the MRI is detection of the significant cancer. So when I say there is a PIRAT 4 or PIRAT 5, it's almost always, I don't say almost all, but with high percentage, you will find a significant cancer. But you can make a transrectal random and you will find prostate cancer 6. And I can say MRI, it's normal. I don't see anything. So this is a critical rule of MRI. So remember that the Gleason score is very important. If you decide to make a biopsy, you should know the Gleason score of the patient, or the patient has a history of previous cancer, you should know about the previous score, especially in case of active surveillance, okay? One interesting point in Gleason score I'd like to keep in your mind. Gleason score usually represented by 2 numbers. You will find that by the report, 3 plus 4, 4 plus 3, 4 plus 4, something like that. The first number represents Yes, the dominant pattern of the cancer. As long as a higher score, this means a more aggressive cancer. So that's why when I say I have a Gleason score patient 3 plus 4, it differs from 4 plus 3. However, the total score is 7. But in case of 7, I should see the summation. What's the number? It's 3 plus 4 or 4 plus 3. Because in this patient has aggressive pattern than this. Because the 4 is the first number, it means that the aggressive pattern here is more dominant. But here, the less aggressive pattern is less dominant. So this patient has more invasive cancer compared with this patient. Okay? So this is a very important point that you should keep in mind. So our rule as a radiologist, don't miss the significant cancer. Any questions at this moment or at this stage? Okay? So now come back for the radiology. So we'll take about, from now, a pure radiological concepts. I hope it will not be boring for the urologist or gynecologist. Okay? So, to start with interpretation of, now we know the value of MRI, okay? We should know the everything about MRI here. And the most crucial point, maybe I don't say this statement in the other courses since 1 year or 6 months maybe, but now I like to start it, is the protocol and the quality of the protocol. Why I'm saying this now? Because now we have a pyramiding score, a score for the quality of the examination. Because one of the obstacles for the MRI reading is the quality of the examination itself. It could be a misleading, okay? And I have a personal experience with many situations. The diagnosis differs completely when you make a right protocol, and very dangerous situation, I can say, because you have some VIP persons, you need to take a decision. You have a cancer or not. In some cases, oh, it has a cancer. This is a big stroke and you have a bigger problem. Okay, we need another opinion. Okay, this is a real case I found. Okay, I can't make a diagnosis by this protocol. So I tailor protocol for the machine and diagnosis is completely normal. So it's very important, take care for this. Now, since 2020, a first trial of scoring protocol system, what we call the bi-qual score. Bi-qual score. This is first trial in 2020, just 2 years, and modified this year, in the beginning of this year, version 1, 2020, and now we have a version 2, 2024, to establish and standardize the protocol. And this is under validation. This protocol, we are working with USA and UK to validate with international study to validate its quality, but the preliminary results is very excellent. So we need a very standardized protocol, okay? So, I don't know if there is some colleagues, radiographers here. I hear that some radiographers will attend, but this is very important for them. Okay. So, the technique of MRI, which I need to be the best quality, should include the following items. Okay? Include what we call T2, diffusion sequence, or what we call DWI, and DCE, what we call dynamic contrast enhancement, DCE, to assess the prostate. If you can see, this is a 3 parameters, 1, 2, 3, okay? But this technique will produce 4 images, okay? Note that these are 3 sequences, but will produce 4 images. All these 4 images are very important. Okay. Another modification of this multi-parametric, what we call now the biparametric. When I don't give contrast to the patient, so I deal with what we call the biparametric, T2 and DWI, or diffusion sequence. So this means that in the current situation, we don't need to give a contrast for every patient. This is the first rule. Is it effective? Yes. Is it effective? So I need contrast in special occasions. Special occasions. What are these special occasions? The current recommendation for the multi-parametric is still the last version, recommend contrast, but the biparametric has a validation, high validation comparable to this technique. DCE, I need it in special occasions. What are these special occasions? First, if you have initial experience, you are in the training period, so you should do it as a routine. If you are starting this technique, you don't have much experience, so you should make this contrast as a routine. Okay? After that, you gain experience, you can make, no, I don't need this patient. If you have enough experience, but the cases will not perform during your attendance, okay, so it's better to inject the patient. But if you will follow the patient, you can say after finishing the other 2 sequences, you need a contrast or not. Okay, so this is 2 major case scenario. Of course, and one of the major important sequence when in the equivocal or the gray zone of the PIRAT. Usually, also we don't need DCE, but in some cases we need DCE. So DCE has special occasions, and the biparametric, if you have much experience and enough experience in interpretation, you can be fully confident with that. But when one expert say that I need contrast, so it should be injected. If you are not absent all the time, inject. If you have initial experience with the examination, inject as a routine. Okay? This is what we call the bi-qual scoring system. This is the version 2 in 2004. So this is my gift for you. Okay? Please, if you can capture the next slide, not this slide, okay? This is, I will give you a standard protocol. Usually it works for every type of machine. It needs, of course, some optimization and some trial, but most of the time it works. Okay? So the first step in your interpretation, you should have a good quality examination. So try capture this. Okay, I will not go through its details, but this is need to be applied for every machine, and you need to sit with the technician and modify and to be satisfied with this image. And of course, you need to see before high quality images, high quality examination to know what's the standard. Okay, it's very important. So if I talk a brief about the H acquisition, T2 sequence is the key sequence. The first sequence should be taken with high quality, without any motion, without any artifacts. This is very important because it is the anatomical sequence which may guide me for other sequences. Okay, the most critical sequence is T2, okay? And the most critical one is the axial. So in many cases, you find that, please sit with your technician because you will find many mistakes they do, okay? Usually, they will start with sagittal, and they may take after 5 minutes or 6 minutes, they go, I will take the coronal, and then will take the axial, okay? No, it's not like that. Should start with the important. Why? Because you don't guarantee the status of the patient. He will persist without movement. He will tolerate the examination. So at least get the much information as you can, as fast as you can. Okay? So start, make the clinician start with the axial sequence. Okay? Of course, should be high resolution. So the current recommendation of version 2.1 to say take axial and another orthogonal plane, sagittal or coronal. No, my recommendation is take to 3. Take 3. Take axial, sagittal, and coronal. Okay? Simply why? Because you will need sagittal as a routine. Why? To measure the volume. So the sagittal, it will be by default present. So the coronal, it will be aided because in some cases you need to know the extension of the suspicious area. It's beyond the capsular outline. And so, yes. Okay, so my recommendation to take the 3 orthogonal planes, and my tips for you, an instructed radiographer, start with the axial. So, DWI. Do you know which is the optimum value of DWI? This is for radiologists. Prostate. 800. There is more? Aladon? Alade? Of course. 800 or 1000, it's for the general abdomen and pelvis. Okay? Shouldn't be least than 1,400. 1,400. You put 800 or 1,100, you lost the exam. You lost the exam. Okay? So it shouldn't be less than 1,400. If you can to higher, make it higher. 2,000, okay. 1,600, okay. As much as you can, okay. As this is the what determines this, the quality of the diffusion sequence and the performance of your machine. Okay. Prostate needs to be understand many points about the physics and about the technician behavior. Okay. Now, recently, I don't know, in Philips and GE, okay, they have what we call synthetic diffusion. Synthetic diffusion. This is a new software. I don't know about Siemens. Synthetic diffusion means that they take any p-value, maybe say 800, and patient go home, no problem, and they can modify to 1,400, 1,600, 2,100. They will tell you like that. It's wrong. This is a wrong, okay? You should the primary diffusion sequence, not one of these high sequence, okay? Not less than 1,400, okay? If you like to make a synthetic to 2,000, okay, well and good. But don't start from 800, 1,000, and I will make synthetic diffusion to upgrade it. This is not works, okay? So this is a very crucial point. Okay, so can we use the low diffusion? Low diffusion is well not of diagnosis. Okay, I can say make multiple V value, and you know diffusion has multiple V value. I can use from 10, 20, 40, 500, so on. This is for research purpose. But if we talk about the diagnosis, you can do 0 and 1 and 1400 at least, 0, 1600. You should test your machine. You should test your machine to see what's its performance, because 1400, okay, it's good. If I increase to 1600, oh, it will has a noisy image, the poor SNR, so it will not work with you. So you should test your machine. Okay, so what about DC? When you decide to inject the patient, by contrast, you should strict for the following points. Okay? What's important for DCE? Every tumor in human body, and in contrast, what is important for him? If we talk about HCC, hepatocellular carcinoma in the liver, we are rely on the what we call the washout. Okay, washout, it means that the delay time, delay contrast. Okay, if they take early contrast and they make a delayed washout, early washout, or in the delayed phase, so it will go with HCC. No, in the prostate, we are not working with the delay time. We are working with the early. In the prostate cancer, we are relying on the early time of injection. Okay, in the first 30 seconds. In the first 30 seconds or even less. Okay. Yes. If the contrast appears in the suspicious area, okay, I need, because the pattern of the suspicious area of the cancer will take contrast more than the remaining tissue of the prostate. Okay, so I need to take this early time to catch it, to capture it. Okay, but if I'm in waiting and delay, the prostate and the suspicious area will become homogeneous. All of the same will take the isodense pattern of the contrast. Okay, so I need to capture this time. Okay, so this is what we call, there is a temporal resolution. Temporal resolution, you should adjust in your machine. Okay, and this is rely on the machine, again, performance, but don't exceed 15 seconds. Okay, it's range. As long as you less than 15 seconds and you give a quality image, it's good. So the current recommendation from 10 to 15. Okay, before less than 7 seconds. I need to see the first 7 seconds. Okay, but now not all the machines have this powerful performance. So 10 to 15, this is the window gap of temporal resolution. You should adjust during injection. Okay. Okay. This is about technique. So anatomy is very essential and crucial to know how you're dealing with the prostate cancer, because we have many tiny structures in a very small organs. Okay, so we should know the gross anatomy in a simple way. This image actually presents this in a nice pattern. So I can explain here. I've got my mouse working. Yes, okay. Our colleagues of urologists, I think they know the prostate anatomy better than us. We are radiologists, but we'll try to do our best. Okay. In young males, I don't know, most of us lost this period now, maybe. Okay, found that we have 3 distinct zones of prostate. Okay, as you can see here, the outer one, it's what we call the peripheral zone. It's like an apple or core of apple. Okay, this is the peripheral zone. Okay, it doesn't affect by time, and just posterior or just enclosed centrally what we call transition zone, and posterior to transition zone is the what we call the central zone. This is the very important relation. The central zone is posterior to transition zone. Okay, it's very important. Why? Because by growing the age, the most dynamic zone of the prostate is the transition zone. Here, the transition zone is the most growing part of the prostate by age to produce what we call PPH, benign prostatic hyperplasia. So, what happens if this area increase, more increase? Logically, it will compress the peripheral, but will compress significantly the central zone, which is the posterior part of this. Okay, this compression, because central zone actually is a small area, but it will be first affected by the rapidly growing area of the transition zone, and usually it will be difficult to detect an MRI. And if the PPH become more and more, and we have a large prostate volume, it could affect it and make compression for the peripheral zone and make it thin, more thinner. And you will see a prostate case, all of them, or most of them, a transition zone. So why this is important? Because when I'm looking, every area for these 3 parts could harboring a cancer. Peripheral zone, transition zone, and central zone. So my searching protocol to search in the 3 parts, the peripheral zone, transition, and central. But you should know the incidence, the concept of the incidence. Okay? So the concept of the incidence say that 70% will appear here in the peripheral zone because it's most tissues have a glandular grid. However, 25%, say for easy 5% or less in the central zone. So most of the cases you will find here in the peripheral zone. Second, transition zone. Third, the central zone. Yes, but if you don't know this gross anatomy, you will miss central zone because most of the radiologists say that transition zone, central zone, and make a conflict between both 2 zones. It's central zone, transition zone. No, it's very important to know there are 2 different zones here, transition zone and central zone. But to differentiate by imaging, you need to know where you can check, where you can examine, where you can put your eyes to know where is the site of the central zone, where is the site of the transition zone. Okay? Of course, you have the urethra and you have the seminal vesicles and the vas ductus deferens. And here what we call in anterior part of the prostate, it is anterior fibromuscular stroma or AFS. This is a fibrous tissue in the anterior part, usually has no glandular gland. So it's not expected to have a cancer because it no has glands. It's a fibrous tissue. However, you may find that a cancer covering this area. So why this? This is exactly, especially from the transition zone, or if you have a very large cancer occupying the whole gland. peripheral zone, transition zone, and even part of the FS. Okay, so FS usually will not harboring a primary cancer, but usually it will be an extension. So I think this image very representative for the anatomy, which we'll check in the MRI. So what to assess? We should put peripheral zone, transition zone, central, and AFS. Okay, this is the gross anatomy of the prostate. Another important concept of the anatomy of the prostate you should know, and this is in the MRI, what we call the prostate level. Prostate level, I can explain here too. Prostate level. If we have a prostate here, and here there is seminal vesicles and also the urethra, and we expect that this is the site of the bladder. Okay, so we say that we have here at the prostate base. Okay, so we have prostate base as long as we closer to the bladder or the seminal vesicles. So we have a base, because this is very important. This is your landmark. This is what you will report. Where is the suspicious area? Is it at the base or at the apex here? The most distal part of the prostate, it's called the apex. Okay? And what about the area in between? Yes, we call it a mid-prostate, mid-level. If you have a suspicious area here between the mid and the apex, here, for example, you can say mid-apical. This is the left side, so you can, at the left mid-apical side. Or, in another way of expression, I like it much more, you can mark it by the clockwise pattern. I can say at 5 o'clock, 4 o'clock, 3 o'clock, 2 o'clock, and so on, left or right. Okay? This is how can we see the different main levels in the MRI. We have here the prostate here. This is the seminal vesicles, okay? I can see here the seminal vesicles. So what's the level I can expect? Base, okay? And here we can landmark by the symphysis pubis, the distal of the pelvis bone. So I can expect this is the apex, and this is the in-between. However, this is symphysis pubis, but this is the last area of the symphysis pubis. So we have an apex, mid-level, and basal level, okay? If you can see, I will describe MRI anatomy about this image, but I will show you a live exam. This is what we call the transition zone here. In the adult man, we cannot, it's full with small balls, small rounds. This is what we call the PBH nodules. This is the transition zone which enlarge, and if it's more enlarged, it will compress. This is the bright area, which is called the peripheral zone. This is the bright area, has a characteristic pattern of brightness, peripheral zone, okay? Where is the central zone? Can anyone identify the central zone or expect its site? Can I see here? It's not shown here because it's apex. It's away from the central zone, okay? Central zone, if we come back to the exam, it's found to the posterior and near to the base, near to the seminal vesicles. So this is a landmark when you're looking for the seminal, looking for central zone. You should look at the base of the prostate, near the base of the prostate, okay? And it has a characteristic shape. I will show you. So it will, however, many cases will not be obvious. Many cases will not be obvious. If it is not obvious, it's good because it's not harboring cancer. Okay? Okay, Biorad version, also this is the third concept of the anatomy. They developed what we call the sector map. So we have anatomical zones, we have anatomical level, and we have what we call the sector map. The sector map, they divide the prostate for about 44 regions, okay? And this map, usually, we print it in the final report when we have a suspicious area and make a circle. I can put circle here. I say that this is the suspicious area, or here, or here, or here, whatever. This is for a guidance for the who will take the biopsy. Who will take the biopsy? This is what we call the sector map. Okay. Now I will run some cases to determine the anatomy, okay? To know the anatomy and to know the sequence, to identify the sequence and the anatomy. Okay, this is not ideal, but okay, let us try with this. So this is the axial. What we call this is the axial image. Axial T2, okay? Why we call this axial T2? T2 in MRI has a characteristic pattern for, even for non-radiologists should know. Every fluid, normal fluid, in T2, it becomes bright. So we know the sequence is a T2. So if we have a urine, if we have a bile, okay, so it will be bright. If we have ascites, in T2 will be bright, okay? CSF, this is a fluid, so it will be a bright, a simple physics, okay? So we have a bright organ containing a bright fluid. So what we expect this is a bladder, okay? This is the bladder, okay? And this is the seminal vesicles here. It has a specific appearance here. You can make it this like that. Seminal vesicles here, you can see. It has like, they always say, a papillon-like pattern, And all these seminal vesicles, this is a reservoir of semen, so it's also a fluid, okay? So it can, but it's sick fluid, maybe hemorrhagic or something. But the message point here, we are now at which level of the prostate? Base, the prostate base. Now, prostate now it's not in this image, okay? But we are at the level of the base, okay? So what this? The rectum. And this is what this is not current now, this is endorectal coil. MRI make some specific technique, but it's not, we are not doing it now, but this is one of the cases which we've done before. So now I will go down to check for the prostate. Now I'm knowing that we are on T2, okay? So let's check. This is prostate. Which level? Base, okay? So let's start here. This is which level? Mid, okay? So which level? Apex, the apex of the prostate, okay? What we can notice now, this is, okay, the peripheral zone, this is a peripheral zone. All these peripheral zone. Is it normal? No, not normal, but it doesn't, this is not our issue now. Okay, but what I need to know, the peripheral zone, its normal pattern like that. Most of the normal pattern, high signal, what we call high signal intensity, okay? The high signal intensity of this, it should be all of us, all has signal intensity diffused like that in the peripheral zone. But when become less bright, I know there is a problem, but doesn't mean at all this cancer. Okay, this is very important. The transition zone, which is at the center here, heterogeneous, always has a rounded balls, Like, check this ball. This is the site of transition zone. This is one of PBH nodule. So this is, we are in transition zone. Okay, this is the apex level. We said that we have a diffusion sequence. Diffusion sequence produce two pattern of images. Produce two pattern of image. Okay. What we call the high p-value image, which produced from the 1400 at least p-value, and this is what we call the ADC map. ADC map. I don't know, this resolution is not so good in you. Okay. The first thing when you look at diffusion, you should do what I did now. Adjustment, make optimization to check the quality of the diffusion. Diffusion is a very sensitive technique which could be affected by the patient movement, the capability of the machine, which one is 1.5, 3 Tesla, and so on. Okay? So it's very difficult and it's very crucial for diagnosis. So we need to make it more optimal. We have two different patterns here for peripheral zone, okay? This is the this is the normal pattern of peripheral zone in diffusion. It shouldn't has bright signal. So remember that on T2 it should have a bright signal, but on the first image of diffusion shouldn't have bright signal. Like that, it's low. If it is low, that's good in diffusion, okay? But, okay, should be in ADC always the reverse of the p-value. ADC always is the reverse. So look at to say that this is a normal or not. If they have the same pattern, okay, this is an artifact in diffusion. If there is the same pattern, this is an artifact. But if you say there is a restriction or non-restriction, should be opposite each other. I will give you another example. It's for normal one. Again, so we'll make it smaller because to know the boundaries. Okay, this is which sequence? This is the bladder here. So which sequence? Don't look at this now. Which sequence here? This is a T2, okay? Because the fluid of urine is bright, okay? Usually this is this is the apex level of the prostate because this is the symphysis pubis. Usually when you look at T2, it starts from the apex, not from the base. This is one of the tips I'd like to give you. Look at the apex because most of the overlooked lesions missed when you in the last cuts at the prostate apex. Okay, so and be sure it's included in the scan and start from the apex to base. Okay, this is very important. So now I will go from the apex. This is what we call the prostate apex here. But what about the green circle here? Represent what? This is what we call the neurovascular bundle. Okay? The neurovascular bundle from the apex here. This is a neurovascular bundle. This is a neurovascular bundle. Okay? Usually at the level of 7 and 5 o'clock. It's very important to identify because of the a lesion affect this bundle, so it will give a higher pyrette. Okay, and the urologists need to know if the neurovascular bundle involve it or not. Now we are in the middle of the prostate here. Middle of the prostate here. What can we see? Which is the bright? This is the peripheral zone. Okay, peripheral. Almost it's bright. The almost pattern of the bright. Okay. What about these? The poles here. We are talking about transition zone. Okay. So I will go up. As long as I go up, the poles appear. So this is a transition zone here, multiple poles, and this is the peripheral zone. Has a nice pattern here. I can. Okay. And this is the site of what? Yeah, surgical capsule. This is site of surgical capsule. Urologist, I think. You see actually surgical capsule or it's a landmark? Yeah, it's not. Yeah, it's I think it's an imaginary line. It's not a real capsule. Okay, so this is because what they call surgical. It's not anatomical capsule, but it is a landmark for them, I think, for PBH, TRP. Okay, so this is, we have the peripheral zone, and this is all this transition zone. Now, the transition zone comes through the bladder, so we have a large PBH. Now I got to the base because the seminal vesicles start to appear here. And you can see this is the PBH protrude through bladder neck into the bladder. So what's happened? Median lobe usually project here. This is the one here. Okay. So we have two structures. We need to check the central zone and anterior fibromuscular stroma. If you look at this is the most anterior black area, which is the fibrous area. This is the site of the AFS, anterior fibromuscular stroma. It's fibrous, so in MRI, it is a black, a void of signals. Okay? This is its location here. This is the sagittal, which I need to measure the prostate volume as I measure here. Okay, and from axial, I will take the transverse view. Let's take the another sequence, diffusion. I will adjust and optimize the level. As I said, diffusion will give you two images, what we call the B value, which is this one, and ADC value. And this is the normal pattern of the peripheral zone. It should be low in diffusion, low in diffusion. You don't have any brightness. And ADC should be the reverse. So you can notice that in ADC it's brighter than the B value. So it means that this is a normal signal. This is not an artifact. You found both of them the same signal intensity, say this is an artifact and should repeat the diffusion. Okay? So they will go together. There is no almost restriction in the B value. And at the same time, there is a restriction on ADC or bright signal. Let's talk about bright signal on ADC. You can see, check, this is the smooth pattern of ADC, of peripheral zone in ADC, bright, but this is a low. This is a diffusion. This is the normal. Okay? So I will take another case. Starting with axial. If you notice that all the images start from the apex. First, this is what I'm tailored. I told the technician, okay, I need to start with the A. I need to start with the apex so he can tailor the image for me. So starting from the apex here, this is the first cut for prostate from the blue, the apex. As we are talking about T2 now, T2, so it should be bright signal, okay, bright signal, almost here bright. It has some linear low signal. This is, we know that it is mostly prostatitis, okay. Bright signal, okay, bright signal, and go up, bladder start to appear, so we are at the base level of the prostate. And what this is a very large PPH nodule, median loop almost, so make obstruction. So one of the pitfalls you should avoid, what's this? This is the low area here in the center. Do you know what's? Do you know what's this? Because we'll talk about the typical pattern of cancer. It should be low. It should be low. In the peripheral zone, should be low signal. So when I say I see bright signal here, so no problem. Bright signal here is no problem. But there is a low signal area here. Is it cancer? No. From T2, I can say no. Because this is the anatomical part of the distal part of the central zone. This appears like this, and it's called mustache-like sign. This is a mustache-like sign. This is the anatomical part here, and this is the ejaculatory ducts here, the central cyst here, but this is the central part. The central zone, the best to determine in the coronal, okay? But when appear like that, will appear like that in the axial. So this is one of the pitfalls, because many cases reported this is a low signal, and they give a score and make suspicious diagnosis. No, this is the remaining, the distal, most distal part of the central zone. And as I said, okay, it will appear like that, mustache sign. This is the remaining of the central zone. Like, as you remember, I told you it's posterior to transition zone. This is the large central zone, and they make compression to the central zone posterior, give this pattern. Okay, so this is a central zone like here. The central zone, the best appreciated in coronal, but we can see in the axial. And when you have a suspicious, if you find it asymmetrical, you find one side larger than the other. So here, we have a suspicious of cancer in the central zone, which is very low. I didn't encounter a cancer except in one cases, maybe in the central zone. So here, the seminal vesicles, when I go down, you can see the ducts here will start here and here, okay, in the midline. And prostatic urethra, okay? This is the prostatic urethra here. So where is the neurovascular bundle? Start from here. This is the neurovascular bundle here. Okay, this is the left neurovascular bundle, right neurovascular bundle, and when I go up, it will proceed neurovascular bundle here. Okay, it's very important. If there is a suspicious or lesion here, I can extend beyond the capsule, which is here. This is the low signal. This is the prostatic capsule. Okay, and this is the surgical capsule, which separate between the transition and peripheral zone. But this prostatic capsule, which is the capsule covering the whole prostate. What's this low signal? DFS, anterior fibromuscular stroma. Okay, anterior fibromuscular stroma. What's this in the center? This is the transition zone. Okay, different pattern of transition zone you will find. At what level we are now? Base, and we have a large prostate projecting to the bladder neck. Okay, let us see the diffusion of this case. Diffusion should have two images, the p-value image and ADC image. I optimize my window. Okay, should work, should go with us. I will start from the apex. We have any bright signal here? This is not a bright signal. Okay, there is no bright signal, but here it's bright. Should be opposite each other. Okay, so this is the normal pattern of peripheral zone. As I go up, normal pattern of peripheral zone. And yes, normal pattern because it's the opposite signal here. Diffusion regarding transition zone, it's heterogeneous. We have no rule regarding transition zone except when with suspicious area, okay? But I need to know the anatomical concept. There is no restriction. Restriction here, this word, usually you find it in the report, means bright signal. Restriction, it means bright signal, suspicious bright signal. And the true bright signal. True bright signal, what does it mean? It means that it's a high signal on P and should be the same area, low signal on ADC. So we have two terms you should know about the reporting. We say there is a restriction and there is no restriction. Restriction, it means this is a suspicious area. And we should be confirmed this is a true restriction. Why no? How can I know true restriction? I should find bright signal here. At the same time should be low here. Any situation, the same, the both sequence, the same, this is not real. This is artifact. Okay? So this is a normal. Why? Because this should be low without restriction. How can I know is true without restriction? Because this area, it is higher. So it's opposite. It's the reverse, okay? It's very important. So this is the area of Mustache sign, right? So this is why we call this is the anormal area, okay? We will discuss with the pathology, but we just need to fix the concept of the anatomy. Yes, I will finish last case and go break. ماشي؟ Okay, here is the bladder. How I know this is bladder? Because ADC gave me any brightness or no restriction. So this is a normal. Okay? This is a true, this is a true, no restriction. So there is no abnormality in the bladder. Okay? This is the diffusion which I like to concept. Again, I will show last case to fix the anatomy and go to a break. Okay, starting with T2 from the apex. What do you see? Where is the peripheral zone? There is the peripheral zone here. Okay. Is it bright? Is it bright as the previous cases? It's low, not bright as the previous case. So this means that this is abnormal, but I cannot say it is a cancer. This is abnormal, okay? So I need to check this area in the diffusion sequence. You can notice that this is the prostate, multiple poles, transition zone, and this is the AVS, anterior fibromuscular stroma. So we go to the base and we find that also a large prostate. And this is the site of central zone in the axial. However, it's very compressed. We cannot detect it. So this is the neurovascular bundle at almost 5 and 7 o'clock. This is a neurovascular bundle, This is AVS like this. Neurovascular bundle again. And peripheral zone here is low. So it's suspicious for T2. It's abnormal for T2. So let's check it in the diffusion. I will take these 3 images here. This is the p-value. I will make it here to accommodate for this. Okay, let's focus on the peripheral zone. Peripheral zone here, is it restricted? Is there bright signal? No. Is it real or artifact? Check with ADC, okay? If the opposite, yes, it's low. You can notice that this very thin line, low. So it means that there is no restriction. So this means that this case, it's abnormal prostate, but it's not cancer. It's just prostatitis. Okay, we'll take in depth about this after the break, but okay, transition zone. We have a different pattern of transition zone in the T2 and in diffusion. Could be restricted, couldn't be restricted. PBH nodule has a different pattern. Okay, this is the normal pattern, which if you have any questions regarding this, any questions? Okay. Okay, T1 for hemorrhage or to assess the more lymph nodes and mets. This is could be you do it as routine, but in the real work we don't perform it because if we have a suspicious of PSA, we now replace T1 by plasma PET-CT, okay, for the assessment. But if you'd like, it doesn't matter. It's already reported by the recommendation. But usually if we have a high Gleason score and a high PSA level more than 10, usually we recommend for next step, which is plasma PET-CT, okay? So this is regarding the anatomy and technique. It's very important to understand these concepts. If any questions, any more questions regarding this issue? Okay, after break, we'll go to the pathology to know what's the typical pattern of every Zoom cancer. This is the significant cancer we shouldn't miss. Okay, I don't know, after break or after prayer time.
Thank you, Dr. Haitham. We can go for a break now, and we will meet again after the prayer time. Thank you, everyone, and I hope you enjoy your break time. Thank you.
اللي فاتت اتكلمنا على اول حاجه عرفنا اهميه موضوع البروستات كانسر وليه الناس بتفكر فيه وتعب شغلها بالذات في الويسترن كانتريز، وعرفنا ايه التول الجديد اللي هم قدروا يوصلوا لها واساسيات الاناتومي والتكنيك بتاع المالتي بارامتريك MRI. وقلنا ان اهم حاجه التكنيك والكواليتي اوف تكنيك، وانا اديت لكم يعني بارامترز معينه تمشي تقريبا مع كل الاجهزه، بس محتاجه ان انت تعمل لها تيلرنج للبارامتر دي، محتاجه انها تجربها وتقعد يعني تقعد كده تجرب على بيشنت. يعني دايما انا لما بنزلها على ماشين جديده بقعد اجيب بيشنت واجربها وبتبقى خلاص ستاندرد. في بعض الاحيان بتحتاج ان انت في اثناء فحص حاله ثانيه تظبط البارامتر دي تغيرها، فبتبقى محتاجه شويه تعرف الام ار ارتفاكتس البرنسبلز بتاعتها وايه اللي ياثر عليها، امتى اقلل السكنس، امتى ازود السكنس، امتى ازود الباند ويتس، اما اقللها. محتاجه شويه تفاصيل بتبقى صغيره، لو فهمتها هتقدر تماستر موضوع الام ار تكنيك. اوكي طيب خلاص كده ماشي. طيب this session okay will talk about the BI-RAD itself, and this is the first step of diagnosis. Our steps of diagnosis. First step, as I have mentioned before, the quality of the examination. As I told you, there is a scoring system for the quality. The last version say we have 3 score, 1, 2, 3. If I report this exam as 1, so it's not valid for interpretation. 2, it's possible for interpretation. 3, it should be 3, sorry, this is the best quality. Okay, this is for the last version of the scoring system, and this has become an item of the report. طيب, steps of diagnosis in general. The first step is to detect the lesion. And detection of the lesion, it means that you can describe the location of the lesion. The location means which zone, which level, okay? And you can more be precise and localize its map, its sector map, which sector in the prostate, as we have mentioned before. Detection, you see the lesion. Localization, as I have mentioned. Then you should make individual scoring system for each sequence. We have a 3 sequence in the multiparametric MRI. We have 3 sequence. We have T2, so you should give a separate score for T2. You have a diffusion sequence, so you should have a separate diffusion for separate score for diffusion. And lastly, you have dynamic study. You should have a score for the dynamic study. And the total score, pay attention, that total score is not a summation of the score. For example, if I give a score for T2 for the lesion, this is at T2, I give them 3. Diffusion, I give them 2. Okay? Dynamic study, it has not a scoring system. 1 from 5, it's, we can say, positive or negative, just positive or negative. While in T2 and diffusion, the scoring ranges from 1 to 5. Okay? So if I have a case in 2T, have a score system like 3 and diffusion like 2, the final score will not 5. This is wrong. Okay? This because some have this concept. No, the final score has a specific rule. We'll discuss it now. Okay? So your rule to finish your report by overall scoring. Overall scoring or final score. So the final score depends on this table. BI-RADS 1 from to BI-RAD 5. What's the mean of BI-RAD 1? It means unlikely, very low unlikely you have a significant cancer. And remember that we are talking about significant cancer, not indolent cancer. Indolent cancer, it could be diagnosed by biopsy and couldn't be visualized by MRI. Okay, so our rule to detect the significant cancer, and we understood what's meant by significant cancer. Okay, by RAT 2, we remove the word very to become low, and 1 and 2 are benign lesions. Almost over 95% they are benign lesions. Okay, by RAT 3, it is the gray zone, which I have mentioned in the first session. It is the gray zone. It is the equivocal zone. So when you report the final score of your report, this case is a PIRAT 3, it means that the urologist will talk to you, okay, or you will talk to your urologist. What's your suspicion? Do you have a high suspicion of PSA? Do you have the most specific, because PSA will know it, okay? But the most question for urologist about digital rectal examination. What's your impression about DRA? You have a suspicious? If says yes, okay. So you will recommend the biopsy. So PIRAT 3, it's equivocal, but when I can say after the final report, the final conclusion, this is a PIRAT 3. However, biopsy is recommended because there is a suspicious digital rectal examination. If the urologist say no, I have no strong suspicious, okay? So in this case, I can consider it as prostatitis, just inflammation, which is a pitfall between the cancer and prostatitis. They are similar, okay? In this situation, the patient needs follow-up, at least to be confirmed for a while. The most problematic is prostatitis. So simply, we will give him a chance, take a treatment for prostatitis, maybe for 10 days, 2 weeks, and we follow by PSA. And even by PSA, if dropped significantly, so no need to perform repeat MRI again, okay? A PSA in this case, okay, we can rely on it. Don't forget the PSA density. This is one of the tools, as we have mentioned before. So DRA, PSA density, as long as there is no suspicious, okay. So this is usually, PIRAT 3, this is usually a final decision for the urologist. I can give them a PSAD is for 0.14. It's marginal to suspicious, or some cases, all the parameters are marginal. So the decision here, usually by MDT, radiologist, urologist, and usually the final opinion for the clinician urologist, okay? We can wait, we give him a chance to make a specific treatment, and every case has its own scenario, okay?
About the special lesion, or about the whole prostate, define the whole prostate. I talk about the special part of the prostate, inside the prostate, or the whole gland.
The examination will cover the whole prostate. So when I say PIRAT 3, PIRAT 4, PIRAT 5, so I have a strong suspicion for a specific area. Sometimes the cancer, including the whole prostate. Yeah, and this is, and we may find multiple lesions. So in this case, you will enumerate the lesions as long as you have a suspicious. I have a lesion 1 which is located at region Kaza Kaza, okay? And this is PIRAT 3. I have another lesion at the apex, PIRAT 4. I have another lesion, PIRAT 5. And we are searching for what we call the index lesion. Index lesion, it means the largest lesion has a largest score, okay? So the nature of the prostate cancer is heterogeneous. So you might find one focus. At the same time, I scored it as 5, okay? But you find at the same time 6 after biopsy, okay? So when you're scoring, you score the most suspicious area. And based on your description, this suspicious area, special focus area or involving the whole prostate, okay? So this is based on the MRI. So our rule here, if we notice that, don't miss pyrite 4 or pyrite 5. This is a cancer over 95%. Okay? Pyrite 4, it's high clinically significant cancer. Pyrite 5, it's very high. And fortunately, the difference between them in imaging very easy, just the size. So when I say pyrite 4, it means that the lesion is less than 1.5 centimeter. But if equal 1.5 centimeter or more, so it's pyrite 5 with the same criteria. Okay? So pyrite 5, it means the high risk, higher significant cancer. So the difference, only difference between pyrite 4 and pyrite 5 is the size. Okay, but what if I found a small lesion, okay, say 6 millimeter, 7 millimeter, 1 centimeter, okay, but it's become extend beyond the capsule. So which pyrite I give? Extend to neurovascular bundle, for example, right or left. Yes, you should assign for the highest score. This is a pyrite 5. So the only exception for pyrite 5, if you have a small lesion, whatever its size, and have extra prostatic extension, and usually at the level of neurovascular bundle, so you will pyrite it as a 5. The size here is dropped, okay, is not considered, as long as the lesion not confined to the prostate, okay? And this is concept what we call, and this should be reported, mentioned in your report, is the lesion have extra prostatic extension or not, what we call ECE, okay? This should be mentioned in every report, okay? The lesion has ECE, okay? It means by default, it will be 5, okay? Has no ECE, so you should say it by positive or negative. So if you can consider diagnose 4 and 5, so you will achieve you will be safe radiologist for this case. If you have a pyrite 3 and someone say that, no, it's pyrite 2, I can consider it normal, okay? You are not dangerous radiologist, but you need more experience, okay, to see. And the first point to build your experience is the image quality, is the optimum image examination. And you should make your eye accommodate the high quality images, okay? This is the same. We talk about clinically significant cancer by imaging pyrite 4 and pyrite 5. And this is another point, extra prostatic extension and or the volume. This is the volume regarding the biopsy. The core of the biopsy, if involved more than half of the core, this is a significant biopsy, and we have set the Gleason score before. Also, due to the recent development of prostate cancer, they developed what we call the cancer risk stratification. And I think this is for urologists know that this is one of the tools make the urologist take a judgment for decision of biopsy or not. And it works really in case of which pyrite. How can I use this? When I have a specific pyrite, which pyrite? Pyrite 3, yes. This is unequivocal, so we need a decision. So they developed this categories, low risk, intermediate risk, high risk. So if I have these components, I can make judge for this patient, we can do biopsy for him or not. This is based, if you notice that, about the stage of the tumor, T1 or T2A, and this is, we can conduct it from the MRI, so MRI has a priority. PSA less than 10 nanogram, and Gleason score after a biopsy. Okay? This is another clinical stage, T2P, T2C. So one of the recommendations, and this is favorable for the urologist too, to mention the stage, the stage of the lesion in addition to the PIRAD. Okay? And this is the high risk. These are some remarks regarding the PIRADs. The first point, the PIRAD system version 2 should be based on multi-parametric MRI findings only, okay? But take in consideration the final diagnosis and the final opinion, especially in equivocal PIRAD 3. Biopsy should be considered for 4 or 5, but not for BioWard 1 or 2. What about 3? This is an MDT decision, okay? PIRAD doesn't include recommendation for management. This is very important. PIRAD doesn't recommend which line of management I should parser, even if it is positive. We have a significant cancer, but this is not management because there is some other PIRAD system. We can direct them for different type of management. PIRAD 3, as we have mentioned, may or may not be appropriate for the biopsy, depending on other many factors. I think we discussed it before. Okay. We said before, every sequence should be individualized, T2 and diffusion. T2 have a score from 1 to 5, diffusion have a score from 1 to 5, and dynamic contrast has a score just, you say, negative or positive. What's meant by negative or positive? This is very important. And the technique is very important to help you make a decision for this. When I say positive, when you have a suspicious area on T2 and on diffusion, and this area take early enhancement before the normal remaining tissue. We can say before the background. This is why we look for the early injection, okay? Early time of injection. If we have a such lesion, so we can say this is a positive DCE. When we can say negative, if there is no early enhancement. So I need to check the later enhancement. It doesn't matter to me because even take enhancement later, it will be comparable to the background. So it's a negative enhancement. So dynamic study, or dynamic, when you do multi-parametric, you need to comment for the dynamic study by one of these. The lesion which is suspicious has a negative contrast or positive contrast. So, yes, I will you answer soon. What's the value of DCE? Okay, the value of DCE only for suspicious lesion in the peripheral zone, not transition zone. Why? Because your comment, DBH nodule take many varieties of enhancement, take many varieties of diffusion restriction. So DCE doesn't works with transition zone. So the only indication for only imaging indication to make injection of the contrast or to perform multi-parametric MRI if you have a suspicious zone, peripheral zone, and if you will report it for PIRAD 3 only. If it has a positive contrast, this make the PIRAD, it will be turned to PIRAD 4 or 5 according to the size. So this is only works for peripheral zone, not transition zone. And if you report pyrite 3, you should you should inject the patient to perform, to know is it positive or negative. Okay? So dynamic is not have no rule for transition zone. And this is maybe the highlight which I like. The only effect of DCE is the upgrading pyrite 3 lesion to pyrite 4 in the peripheral zone. Okay? So from here, if I have a strong suspicious this is a pyrite 4 or pyrite 5 by T2 and diffusion, there is no need to inject the patient with contrast. So from here, the frequent use of dynamic becomes declined. Okay? So this is what we said, the scoring system for T2 1 to 5, diffusion 1 to 5, while the contrast is positive and negative. So the question is, how can calculate the final score? We said that if we have a T2, 3, and diffusion 2, the final score will not 5. So from here, we have a concept called the dominant sequence. Dominant sequence. So what does it mean? Dominant sequence means that we have two main zones, peripheral and transition. Okay? We have a zone which has the upper hand of its score, regardless the other score of the remaining sequences. So what's the dominant sequence of the peripheral zone is diffusion. Okay? So if I have a zone in the peripheral zone lesion and graded as in T2 as 3, while in diffusion is 4, the final score will be 4. The final score will be 4. Why? Because I rely on the dominant sequence concept. Okay? So what's the dominant sequence of transition zone? Is T2. T2. Why? Because PBH nodule has heterogeneous pattern, may be restricted or not restricted, as we have mentioned before. So I cannot rely except there is some exceptions we'll take it about. But the dominant sequence of transition zone is T2. Is T2. If I have highest score on T2 and the lowest score on diffusion, so I will rely on the highest score of T2. Of course, we'll see more examples for this. This is if you have a multiple lesions, lesion 1, lesion 2, you should enumerate them and report them, every one individually by its wound score. This is the screen capture from the manual of the ISUR and the American College of Radiology. I intentionally this is manual, as I told you before, is very important, essential for, especially in the beginning. Describe how you describe the lesion in your report. So I recommend everyone in the beginning of your experience to try to use these terms. If you have a lesion of pyrite 1, okay, on T2, so write uniform hyperintense signal intensity, which is normal pattern for the lesion. Okay, if you have a pyrite 4, circumscribed, homogeneous, you can select from which circumscribed our lesion, homogeneous, moderate, hypointense, focus mass, whatever. To try to use this expression to be familiar. So one of the purpose of the pyrite all over the human body is to standardize the report. So to standardize the report, try to standardize the terminology of the report. Okay, so this is very beneficial for description of the report. which help you to pick a standard. Because I read the report and USA read the same report, they will understand what actually mean. Okay, but don't say this is a Pirate 4 and stop. Give a description, because maybe you see Pirate 4, I see Pirate 3, whatever. So, and you will find some words, 2 words actually in this manual, which may be confusing. Even was confusing for me, even till I asked my mentors in USA, what's meant by circumscribed and rounded lesion. You will find these 2 terms, circumscribed. You know what's the difference between circumscribed and rounded lesion? Radiologist, circumscribed? Yes, rounded? And rounded definite margin too. This is why it's confusing. No. I don't know if there is a pen. Circumscribed means have angles. Maybe almost at the shape of the circle, but it has angles. It can like this sharp porters and angles. Okay, this is a suspicious. It's not smooth. Rounded, it means that it's smooth porter. Okay, this is one of the difference terminology. Even me, I was confused what it's circumscribed. Usually we say it's rounded lesion, whatever. No, but you will find circumscribed means that it has angulated margins. Maybe in a complete circle, but it has angles. Okay. So let us take example for the peripheral zone T2 Pirate system. So this is the normal pattern of Pirate 1, which is usually for peripheral zone. You can notice that uniform signal intensity. So we will focus now this session for peripheral zone. Okay, so forget transition zone now. Okay, the peripheral zone now has a smooth which pattern, high signal pattern, bright pattern. Okay, as long as this is a perfect normal, I can assign for Pirate 1 with no doubt. Okay, perfect peripheral zone on T2, bright signal, homogeneous, no problem. The concern always regarding the low signal. Always the concern regarding cancer or abnormality regarding the in T2 is the low signal. Okay? So this is a Pirate 1. This is the commonest pattern you will see for the prostate MR. You will, most of the time, you will find just lines, multiple lines in the peripheral zone, these lines of low signal intensity. Okay? So it's not completely bright, homogeneous signal. This is an example of prostatitis. This is a typical pattern of prostatitis. Okay? Even prostatitis may be not symptomatized. This could be chronic prostatitis. Everyone has infection. It doesn't mean that patient in acute symptoms or came to the doctor and seeking for advice. No, it just, you might find just prostatitis. So this is the linear pattern of the prostatitis. Can anyone tell me which level of this? Which level of the prostate? It's not base, okay? Mid-apical, okay, يعني ناحية الأبيكس towards the apex more. Okay, as long as we go down, you will find the peripheral zone, it's the dominant as a size, if there is no significant BBH, okay? If you have a prostate volume, normal prostate volume, and have a small prostate volume, in this situation, the peripheral zone has the major part of the prostate, especially from the mid-level to the apical level, okay? So this is, how can I describe this pattern? This is, as in the manual, linear, okay, indicated by the arrows, or wedge-shaped, or diffuse mild hypointensity, usually in distinct margin. This is not a diffuse, okay? And remember that The magic word for cancer is focus or focal. When you find focal lesion of low signal, and focal here, it means almost like a circle, or circumscribed or rounded, but focal, cannot diffuse, you have a suspicious of cancer more than diffuse. So I have always concern with the focal area, okay? The focal area. So this is not a focal area, this is a linear pattern, this is a wedge shape, you can describe it, or diffuse, mild diffuse here, this is multiple diffuse lines at the different level of the prostate. You can find it at the mid-level, the base, and you can notice this is a prostate of young male because this is the transition zone. Almost transition zone here is not large. Okay, so what about this lesion? If there is, it is pyrad 1, can I say pyrad 1? Which area I can assign it for pyrad 1? Talk about peripheral zone, okay? Yes. This one I can assign for pyrad 1. This one can assign for pyrad 1, okay? But these are not pyrad 1, okay? So you ask, this is 4 or 5, we'll check, or 3. So pyrad 3, as this thing, heterogeneous signal intensity or non-circumscribed, it's not angulated. You have on the right side, it's like a wedge, large wedge, not linear as in the previous case, but a large wedge area of low signal intensity. And here it's almost rounded, okay? They say non-circumscribed around it, moderate hypointensity. So I will assign this for pyrad 3. This is suspicious. But what about the final score? Not yet, because I will rely on diffusion, because diffusion is the dominant for peripheral zone. He has the upper hand. He will tell me this is a pyrad 3 or pyrad 4 or pyrad 2, whatever. Okay? This is maybe a form of prostatitis. Could be like that. Okay, now come to the Don-Mess lesion. If you notice that this is, we can say pyrad 4 or pyrad 5 based on what? Based on the size. So what's the difference in this case from the other case? Anyone say? Okay, leave the extra capsule now, but what's the... No, this is T2. T2 without contrast. What? Okay, there is a hypodensity, and all of the from 2 to 5, there is a hypointensity. We say hypointensity. Clear more, yes. Yeah, I think you know, but you cannot able to describe as a radiologist. So, okay. So, I said just while the magic word is focal. Focal. If you can see, we can make a margin. Oh, this is a big ball of low intensity here. Okay. This is a level of apex. Okay. So, big ball of the apex here on the right side, and even on the left, I have another area of suspicion. Okay. If you can see, this is the remaining normal. This is, I can assign for 1, okay? But this is what about this 4? So when I say 5 or 4, yes, this lesion I can say 5 or 4 based on what? Size. Okay. So this is example for pyrad 4 or 5, whatever the size here, it's not matter, we can measure it. So in such case, I will describe it as T2 pyrite 5 or pyrite 4. Okay? The question is, how can measure the lesion? This is also an important point. Maybe some ask about it. How can I measure the lesion? And this is important for the colleagues, technician, because it's easy. Of course, multiparametric is not reported through films. Okay, let's agree for that. I cannot print out films and see, okay, it's pyrite, it's not, I wouldn't recommend, okay? Many cases came to me like that, but I refuse to comment and give the final conclusions. I need to see the exam as a DICOM viewer, at least, okay? So, if you like to measure the lesion, always, what? Someone? No. It will be rely on the axiom. The measurement will be on the axiom, okay? But it's the longest dimension. The discriminator is longest dimension. If you take this lesion like this, as we usually do, from this one and this direction, okay. But you will take the longest dimension, and this is what you will report. If, for example, this is a 1.3, and this is 1.5, so you will say that the longest dimension is 1.5, and we consider it as pyrite 5. Okay, so this is very important to be measured. Okay, some other question ask which sequence I should measure. The logic sense say that if there is a peripheral zone lesion, so I should measure on the largest one. Every case will be the largest one, but which sequence, which dominant, the dominant sequence, which is diffusion, okay? Diffusion sequence, because the diffusion is the dominant for the peripheral zone. The most obvious, okay? But I am here diffusion, talking about diffusion as a whole, B value and the ADC value, okay? So, but if the diffusion is not clear, okay, you can measure easily on T2, no problem. Mashi? And T2 the same. This is regarding the T2 lesion, or T2 score. So what about diffusion score? This is a big table, maybe some confusing. However, it's very easy, especially in the peripheral zone, not confusing at all. We check the normal pattern of diffusion of the peripheral zone, which is, in the B value, should be low. Or by radiological term, we write, if you find this term, no restriction, this means that low darkness, or can say dark, no brightness, and this is normal in the B value. However, you should be sure that it's bright in ADC. Diffusion, we have mentioned, diffusion will produce two images, what we call B value image, or roughly we can say diffusion image, and the second image is ADC, okay? ADC value should be inverse each other. If there is one bright, should be the other one is low. To say this is a true signal. If both are the same signal, so this is artifact. Okay? So the normal peripheral zone signal on diffusion, on B value, it's low, and on ADC should be high. Like this. We have different examples in the first session, but I will give you, this is an example for the different pyrites. Okay, the first one, this is a typical. Also, I bring it from the manual to see this is the complete. This is the pyrites one. This is the diffusion. The peripheral zone like here, it's homogeneous low. In the same time, ADC is homogeneous, bright. So this is a true signal, and this is the normal pattern of PIRAD1. Okay? And this is the descriptors for the diffusion score. No abnormality seen on diffusion, p-value, and ADC. What about PIRAD2? Okay, PIRAD2 also almost, you didn't find some linear or which hypointense and maybe hypointense here on ADC, this is the line, and may find or may not find any restriction or bright signal. And came for PIRAD3. Okay, PIRAD3, I will give you the typical and come back to the table again. But remember that this circle, focal, as long as the lesion become focal, so it's more suspicious. And the signal is not markedly at both. What does it mean? It means that the cancer focus, let us jump to PIRAD4 and 5 to understand this. The last image here. This is diffusion and this is ADC. What you notice here? There is a very brightness here, and this is a very low. Okay, this is the significant, this is the typical pattern of significant cancer. Okay, very bright and very low, and should be inverse for each other, as we agree. If we come back to the PIRAD3, we can notice that it's low here on ADC. But what about the brightness? Is it the same like that? No. From here we can say PIRAD3. This is the gray zone, equivocal. Okay? Equivocal area. So, when you are looking for cancer, keep in mind first, you don't have this image in diffusion. This is a PIRAD4 or PIRAD5 based on the size. Okay? Very bright and very low. This is the most concerned, yes, this is the most concerned pattern to diagnose significant cancer. Very bright and very low. If one ISO or moderate, so we can consider PIRAD3. Other these forms, it's not focal. It's just linear, with shape or something, forget it. Okay? You cannot mention in the report. Okay. I will jump this. This is for a transition. It will come the next session. But I need to explain what's the mean by extracapsular extension. After this, we will examine different cases. We have agreed that the difference between PIRAD4 and the PIRAD5 is the size. However, whatever the size of the lesion, small or large, and extend beyond the capsular margin, so it will be PIRAD5. Okay? In some occasions, we find small lesion, okay, but touching the capsule. Touching the capsule. So the question is there is extracapsular extension or not? They agreed that if you have a broad capsular contact more than 10 to 20 millimeter in the curvy linear length contact between the lesion and the capsule, you should assign as there is extracapsular extension, positive, and will be assigned as a PIRAD5. Okay? So you will measure the lesion, how much it is in contact, with the capsule. If 10 milli or more, so you have a very suspicious, there is extracapsular extension. This is the most tricky part for extracapsular extension. However, the other is logic. If you find the tumor extend to the bladder, to the seminal vesicle, to the rectum, have a high lymph node, have a bone metastasis, so we don't have to say this is a PIRAD5, this is, we are dealing with significant cancer. So, but the most tricky one is the the contact of the capsule. Another point here, which is the capsular bulge. For example, if I have a lesion, but the contact or touching the capsule in 5 millimeter, so will not rely on the last line, okay? But make abnormal contour, bulging of the capsule, okay? Disforming the capsule, disforming the prostate at this region. So also this is another point to consider. There is extra capsular extension, okay? So remember these 2 points for determination of there is extra capsular extension or not. Okay, any questions regarding this? Because now we transfer to the clinical cases. Any questions? Okay, so you will answer all the cases now. So let's start with this one. Okay, strategy of breeding, as I said. Of course, if you have a sagittal, okay, this is very important to measure the prostate volume. Usually, I start with T2. Sometimes I using 6 layouts, 6 windows like this. I will give you an example for what I really did. I can use this 6 and put axial, coronal, sagittal, ADC, and diffusion, and the contrast. These are 6 parameters to determine, like that, okay? This is my workstation, okay? T2, this is the ADC, and this is repeated ADC. I will give you sagittal here and the contrast like that. I have no coronal for this image, so usually this is what I start. T2, ADC, diffusion, sagittal, and I can put coronal here, and this is a contrast study to make a layout. But what I really did after that, I click the T2. This is the key imaging, first one. So I will start from where? From where? I will start from the apex. The last cut, please. Many cases overlooked because you are missing the last cut. Start from the last cut, from the base, from the apex to the base, okay? So let us start and with T2, and we'll try, based on what to say, give the individual score for the peripheral zone lesion, if there is a lesion, okay? This is the starting part of the prostate apex here, okay? Prostate apex, here prostate apex, and here is neurovascular bundle, and neurovascular bundle. Okay, I will take a little chair for this. Okay, I will scroll and notes with me if there is any suspicious area, okay? And try to focus on peripheral zone only. Did anyone notice anything? On the right side, at which level? This is the localization of the lesion. Right side, okay. Which level? Apex, mid, base? What? Yes, okay. Which level? Apex or? Okay, this is a level amid gland. It's a little bit lower. We are here before the end of the process, so I will consider it's apical. Okay, if we can notice that this is the whole, I can trace the peripheral zone. This is the peripheral zone like that. This is the level of the surgical capsule here. And this is the whole peripheral zone. Here. All these peripheral zone. So, can you trace the lesion? The right side, which one? Yeah. Why? Hypointensity, okay. And it is focal. Remember that, the word focal, okay? Focal, okay? So what about left side? But still suspicious, because remember that it's not linear as PIRAT 2, it's not PIRAT 1, so at least it will be PIRAT 3 or 4 or 5, okay? So 1 and 2, forget it, it's normal. But you should, this is 2 lesions, one at the right and one at the left. You should be scoring every lesion as long as they separate, because maybe you will find them in the upper cuts, they are continuous as a one lesion. So, okay, how can you measure this? How you score this lesion? I think it's much more 1.5, okay? So it will be assigned as PIRAT 5, okay? So let us go to diffusion. Diffusion has 2 components, as we have mentioned, ADC and diffusion map. I will focus on diffusion image only and will bring this 2 layout. Okay. This is the diffusion optimizing, and this is the ADC. So, what do you notice? Yes? Very, very low ADC, okay, and very bright on diffusion. So, and the most important, this is the same area of suspicious on T2. This is the corresponding area on T2. That's true? This is very important to have a correlation. This is a one examination. Don't separate each sequence as a whole, okay? You're scoring now the suspicious area on T2. You assign this for T2 as 5. What's about diffusion? 5, okay? It's very low on ADC map. This is what we call ADC map, and very bright on diffusion, okay? So diffusion here for PIRAT 5. So what about on the right side? The other area. You have 2 suspicious area on T2. It's like that in Odyssey. It's like the other side. No, okay. So mostly this is you can assign as it's not equal, okay, but the same. It's a mild low fill ADC and a mild bright in diffusion, or you can consider a bright in B value in diffusion and a mild low. So we can assign this is for PIRAT 3. So you have on the right side PIRAT 3 and on the left side PIRAT 5. Okay. So when I describe this location for the whatever who will take a biopsy, you will say that there is a significant lesion on the right apical peripheral zone, the left apical peripheral zone, right apical peripheral zone, okay, and a pyrite 3 on the left apical at the same level. So the biopsy should be target this area, okay. This is considered a large lesion and maybe it's homogeneous completely in the transrectal ultrasound and could be low, okay, so you are lucky. In this case, you can target it easily, okay, but in this case, the right side, usually you will find nothing. You will not find nothing. Will be ISO for a transrectal ultrasound. So it's very important to take from this, which will be not noticed in the ultrasound. Okay, this is the value of MRI. Target you for the obvious and the non-obvious area, and the final judgment for the pathology. Okay, this is what's the important. Even so, what you should know an important point. The pathologist determined the Gleason score according to the volume of the core. The volume of the core, okay? So, if you don't take...
How much is possible?
Yes, one of the volume, more than half of the core. What if just you take a tip of the needle like that, here, or here? This is a significant. We sure this will be cancer, okay? What if the tip of the needle just reach here? Because you don't know there is lesion here or not. This is the crime which I have discussed with you, because I'm taking blindly before MRI. I will take this, okay. I can miss this level at all, okay, because it's manually, I can miss it at all. I can take from above, I can take from below, and miss this level. So, patient may be just prostatitis or even low Gleason score or normal, whatever, and we have a dangerous cancer here. Okay? So it's very important to request MRI in suspicious cases before biopsy. The question here, what if the patient came to you as a radiologist and he did biopsy since 3 weeks? What you will do? You will perform the exam or not?
Not what?
If the patient say that, yes, I had a history of biopsy since 4 weeks, 5 weeks, to be sure that there is no... What interesting point is the hemorrhagic area of the prostate is normal. Doesn't have cancer. Doesn't have cancer. Because they still have the cancer may be the area of biopsy not show hemorrhage. Okay. wait at least 6 weeks to 8 weeks if you have such scenario. If you have a previous biopsy and you need to perform MRI. So, okay, this case need contrast? Yes? No need, you so become expert. But all right, it has a contrast and I will show you. So now we know the suspicious area. Where is it? Where it is, okay? So I will stop here. In this situation, I'd like to check it from the ABC. Or here, okay, this is doing differently. I will go to, this is the dynamic contrast, and will scroll. Then notice that this is the early sequence which has highly uptake of contrast. And you notice that this is a highly uptake is there is some remaining area without contrast here, and here on the left side. Okay. On the left, you hear me? This is at both sides released a cancer at the right and at the left. However, the right, it has a Gleason score 8, and this is a Gleason score 7. Okay, this is the Pirate 3. So this is what it means. This is
every possible cancer. So we looking for the early time of contrast. We don't wait for the wash out like other tumors, most of the tumors in the body. Okay? But as we have said before, this is not need for to inject the contrast. Okay? Any questions? Of course, after you finish and you found positive prostate, don't miss to check the other organs of the pelvis, including the lymph node, okay, including the lymph nodes and the bone pelvis. Okay. So I make a check, and some radiologists try to start with a screen. It has everyone has experience time, but I can check for the highly suspicious lymph node for here. But when I say there is a suspicious lymph node, okay, the pelvic lymph nodes, when I have around the lymph node, and you will measure which axis, 1 centimeter in which axis, short axis. Okay, short axis is the most important. Is the discriminator to say suspicious lymph node or not. Okay, the short axis, not the long axis. Of course, if you have a significant cancer, so you cannot say that this is the suspicious area is moving, and this is one which could be, but however, it's focal. Note here, this is the one point. Maybe if the zooming area was not clear in the papers, but what do you think about this? Yes, this is extra extension compared to the left side. Okay, this is here. There is interruption of the capsule. Okay, and even you notice that there is a bulge. This is what we call contour bulge. If you compare to the left side, it will find that this one is a more living head of bulge. So we should get into the extra capsule extension. Okay. What this structure is? TV5 was with the visceral ear. Okay. Then what's this prostatic visceral? Okay. Now I'd like to move. I will. It's not. We'll check another case, but anyone like to drive the case? Anyone? You can make competition between radiologists and biologists. We get. No, I think you have a good performance actually. Okay. Yeah, and the bottom. It's really made the skin like this. I think my voice is perfect. Yeah, thank you.
I want to say that another one case here. Yes, okay.
Would like to start?
I start. No one like to try himself? Okay. This is a T2. This is without indirectal coil. Okay. So I start from the apex. So if anyone notice something, let me know. Huh? What about this level? If there is any suspicious? Okay, at what level we are? No? What this? Seminal vesicle. So yes, near to the base, okay? Yes. So at the level of the base, what we are usually say is a pitfall? Yes, who said? Oh, central zone. Ah, yes. So you remember this is a big mustache sign here. Okay, this is usually reported like that. So many reports like cancer. Okay, and even the problem is Pirate 3 is a gray zone, but is, I don't know what how it can say, it's survival for radiologist who doesn't have much experience. He doesn't know. Yes. So you find many cases. Pirate 3, Pirate 3, Pirate, okay? It doesn't worse to have Pirate 3 at all, okay? It's either painful, it's either one or two. So don't be aggressive for Pirate 3, okay? Unless if you have a really Pirate 3, okay? So this is the pattern of, I will check, this is for, there is a coronal. I think it will be good, phi coronal. Yes, synchronal here. Okay. Yes. Why looking for the coronal? Because this is the most area can visualize the central zone. This is the central zone, like that, I hear. Yeah. Okay. And even this is not so clear because in the classic form, it has two separation. You can separate it as two bundles, right side and left side. But this is some sort here a fusion. Okay, it will give the like a shape like that. Okay, right side and left side. But this is the side of the transition zone. Okay, this is the coronal. Okay, it's very important when make a correlation. So do you anyone notice a suspicious area? Hmm? Okay, at which level? Here we can say the level easy. No. Apex. Yes, this is the apex. We are now in coronal view. Okay, this is the bladder, this is the apex, and we have a suspicious area. Okay, so I will say that it's 1.5, but I will rely on the classic standard, which is T2. Come back to T2. But this is important. I come back to the coronal here for what? There is important point here. I can, I don't know, make if I say it's 1.3. So, what do you mean Venus? You mean venous bundle or neurovascular bundle? Yes. Yes, the extension. So, do you have any one opinion regarding the extension? We say two rules which usually subtle. No, if Dutch capsule more than 10 to 20, some say 10, some say 20, and the bulge. So what do you think here? This is the capsule here. Okay, I'll make focus here. Okay, this is a bulge, and there is a wide extension. If I measure here, you know that this is the low line here is the capsule, but if you compare to the other side, you will find this is a bulge here. Okay, so this is definitely extra capsular extension. So I signed it for Pirate A5. Okay, whatever the size of the lesion. Okay, so this is the value to have the 3 orthogonal planes of T2, as I told you in the first session. You need to, because this will obvious in the coronal, maybe on more clearer than the axial. So I will come back to axial T2. Where is it? Yes, that's okay. And here I can say there is definitely bulge. Okay, definite bulge. But maybe the contact area here is less than the coronal. So I will rely on the coronal, on the contact area. If there is no bulge, but the contact area here may be, say, 7 millimeter, but in the coronal I found it is larger, reaching to 10 millimeters, so I will rely on the coronal. Okay, I will rely on the sign which give me more a risk lesion. Okay, so what's the next step? So you can not set this cut. This is what we call the circumscribed. It's not rounded, not smooth. It has speculation. It's like lung nodule. When you have a suspicious lung nodule in CT, especially if it is have what we call speculated margin. This is like that. Okay, so what's the next step? I should look for the dominant sequence. Okay, ADC and diffusion. This is the p-value, I think. No, this is the contrast. I didn't. Okay. Okay. This case done, we done it for test multiple sequence, so all these sequence may be not required. I am talking to my colleagues in the technician, so it doesn't take all these sequence, but which I find that, okay, if we rely on the diffusion, we'll find this one, right? Okay, can compare to the left side, there is nothing. Okay, so I'd like to see ADC. This is the ADC map. It's very bright and very low. As long as you said very, so you have a very significant cancer. If you have one is not comparable, maybe find very bright here, but you find mild low. Okay, this is the case of BI-RAD 3. You understand? This is the concept. Okay. This is one of the VIP person which have a problem. And this is solved after optimization of the technique, okay? You should know this is because if you will go into prostate cancer, you will find many important person for like that. Because as long as the responsibility of the man increase, his prostate increase too. Okay, so let us start our rule from the apex. Stop me when you find something. At which level we are? This is a bladder, okay. Only? Transitional here, right? Okay, don't look at transition now. Focus on the peripheral zone. You have on the both sides a low signal intensity, okay? Exactly, yes, that's good. So I will go down. Okay. So, do you have suspicious of extra capsular extension or something? Where? The left or on the right? On this side, left. This is the right, and this is the left. Why? Yes, capsule. And I think, yes, I think you noted that there is a bulge here. This is the contour here. Okay, you can find that. Okay, so is that enough? I can say which PI-RAD for this lesion, for T2? Which PI-RAD? It's 5. So can I finalize my report? We should check for diffusion. Okay. I will start from And you should always look for the prostate as a whole, and the most important, the suspicious area on T2. Okay, so let's start with from the base. I will start on the reverse side. Yeah. Yes. Market high, market low. So there is, okay. No one can blame you. Okay. Now, this is a bulge. Okay. And this here on ADC. So you have a pyrad 5 on diffusion. Okay, let's check. This is no need for contrast, but we will check. This is the level. I adjust the level of the suspicious, and I check here. To me, this is not, this is a negative. If we apply the rule, this is a negative, because the whole prostate, the left and the right, became enhanced at the same time. So why this? How can I explain this? Yes, could be technical. Okay. I will be sure this is the early image or the late IA. But you noted that the center of the prostate enhanced early, which is represent transition zone. So transition zone has only one sequence which rely on mainly T2. Dynamic has no rules. Look, oh, if I said that this is early enhancement here, this is a PPH nodules, okay? Because it usually take any pattern. Could be early enhancement, no enhancement, heterogeneous any pattern. So okay, so I will consider this is a negative, but what's the final score? Dominant sequence 5, this dominant sequence. Okay, okay. When you'd like to take a rest, let me, because I will not stop. Let me know, because he told me stop now, but we start late, so I need to check most of the cases here. Can drink water. I think you have experience now. Can anyone try to check by himself? And let's discuss. Huh. He will take a prize. You will come? Come. You're a radiologist. Scroll image by image like that. كده بننزل لتحت كده بنطلع فوق. Okay, I will say here and give me your opinion. تطلع الهواء.
Is the right apical hypointense area here?
ممكن
Right
تستخدم
apical.
الماوس I keep that. أيوه.
This area.
Okay.
Okay. This is right apical.
Exactly.
Hypointense. Not markedly hypointense yet. It is hypointense. Then we have this area at the base, at the right side, left side. Sorry.
What do you think this area? The base.
Mouse tissue, I think. Fibrous tissue. Yet I have to see the diffusion.
Fibrous
For-
tissue.
Hypointense related to
It's continuous with.
continuous with seminal vesicles after.
So what's this area?
You
This
say
is the central zone.
central zone. Okay.
Okay. This is a pitiful central zone.
Okay.
So we rely on.
So we have this area.
And what about the left side? The left side, yes. I think there is. It's the same level, yes.
Same level. This
Left
area.
side, left
Yes.
side.
This level. You mean?
Yes, yes. There is another suspicious area
It is not very obvious.
on the left.
Streaks of hypointensity. Okay.
Lines.
Or lines.
Linear.
Linear.
line of
Linear
the signal.
hypointensity.
So
Yes.
this is commonly with pyrad. Which pyrad?
Two.
Two. So it's better to report it.
Okay.
Okay. Because there is someone may say that no, there is another hypointense area and you missed it. So it's better to report it, to say this is linear another areas on the
Yes.
left apical region. However, it's pyrad 2, mostly prostatitis.
Okay.
Okay. It's very important to.
Sequelae of prostatitis, previous prostatitis.
Yes.
I think. Okay.
But the most suspicious, which is the right one.
Yes.
So what you will do,
I will see diffusion.
and which pyrad you will assign for this?
I can measure it more or less. I think less than 100.
4 or 5. You can say
Yes.
4 or 5.
Yes.
Or
4.
3. What do you think? Is it focal? Focal, it means limit. It is circumscribed or rounded.
Not
It's
circumscribed.
linear, some sort.
Yes.
As, however, it's not like on the left side. It's not seen linear. It's a broad
Yes.
band.
Patchy area.
Okay.
Hypointense.
So we can assign 4 pyrad.
3.
3. Okay. So let's check the next step.
Diffusion.
I will give you the. You can change layout. Okay. This is the ADC. And this is diffusion. I will adjust it. Oh, you can scroll now.
It is restricted here. This is the same level
Yeah.
of this lesion right side. It is have high signal at diffusion images and low signal at ADC. At the
Yes,
same.
but
This
you
one.
can say make a strength. What's the strength of the restriction and what's the strength of the
Not
low?
markedly. We may say moderate.
Moderate low on ADC, but moderate low on the p-value. Moderate brightness.
At B value, I see it is faint.
Faint.
I'm not sure because this images of diffusion not very clear.
Okay. The issue of diffusion is need to test. In my opinion, it's bright. Okay. It's more bright.
Okay, this is more.
Okay.
Ah.
And
And this is low.
This is low. So, which pyrad you assign?
5. Now 5
5.
for diffusion.
Whatever, 4 or 5. Take يعني it's 4 or 5 based on the diffusion. Okay, based on the size. So,
And also, this question for you, Dr. Haitham, also. How can we may suggest, I may suggest it is moderate, and my friend suggest marked diffusion, and it is for subjectivity. I see.
Yes.
How we this conflict
This is
with others at any case, at every case.
This is the problem of prostate MRI, in diffusion especially. You need to look many cases to make a judgment when you say mild, moderate, or severe. Okay? Don't forget, or don't say, I will measure ADC. If you will, or anyone ask about ADC. ADC is, for our colleagues in urology, ADC is an objective tool. We can use it and give other a number. Okay? This number is not validated because it differs from machine to machine and differ from the strengths of the MRI Tesla, different Tesla.
Yes.
If we have 1.5, it will give me, of the same case, another ADC value from 3 Tesla and so on. The brand himself, Philips, will give me a cutoff value differs than Siemens, differs than GE, and even 2 machines from the same factory may give different ADC. But the trick here, when you can utilize the ADC effectively, test your machine. As long as your machine will stay with you 5-10 years, you can test it for every case. And every case, every machine has its own cut value. This could be of value or help you. If you have a Siemens machine, for example, okay, I will test in every case the benign and malignant, and I can make a cutoff value for benign and malignant. This is an individual tool. You can use ADC, but we cannot standardize. Okay? The only standardization is you accommodate your eye when you say moderate, when you say mild. And the trick here, you should optimize your window here. You should make optimization for the window here. Okay?
In any diffusion, yes.
Yes. But if you come here, come and see the case, maybe the light, I think if you come see here, I think it's bright, more significant bright on the No, this is depends on the shape of the lesion and its size. Okay.
So that was bigger. Okay.
Yeah. So it will be 4 rounded of the. No. This is high definition screen. This is just a projector. Yeah. But when you have suspicious, look at ADC. ADC usually
more accurate, I know.
Yeah, ADC when become a low dark, more dark, try to optimize the B value. If you can say moderate, yes, it's comparable to ADC, or it's faint, so we shift to pyrad 3. So which final pyrad?
4, regarding size.
Regarding size, so we have a pyrad 3 on T2 and pyrad 4 on diffusion. So we apply the dominant sequence rule. Okay, so it will be pyrad 4. So it should be biopsy. This is patient 4 biopsy.
And
Does
also,
we need a contrast?
We need contrast. No problem.
لا هو it's a matter of no problem. We need it or not. The contrast
will be pyrad 4.
add additional value. Will add additional information. Will it change my score?
No.
So we don't need.
Yes. And also regarding extracapsular extension, I don't see signs here for extracapsular
so
extension.
So the point is, you don't make it as a routine. You waste your time, the time of the patient, cost of the contrast. All this, there is no need to perform it as long as you don't have a suspicious, or you don't have Pirate 3. The only scenario, if still Pirate 3, okay, on diffusion, in this situation, yes, I need to inject contrast. Okay, got? ماشي. شكرا. I think this case has a contrast too, but I will check the contrast with you if this is positive or negative. What's this? The two symmetrical low signal intensity at the base. What do you expect this? This is the central zone. Okay, this is the central zone. The normal central zone like that in diffusion. Okay, you saw it in T2, but in diffusion like that. Remember, they are the symmetrical, okay, and at the base. Okay, this is spacious area here. Okay, I will go to contrast here. You look that this is early enhancement here. The prostate, all the, you know that this is all, this is as a area cover the base of the apex. So this is a large area, and may the contrast make it more clear, because this is the positive early enhancement. Look, the whole apex here is show enhancement. Okay, so this is a positive. When I report, this is a positive DCE. Okay. You need a break? Someone say yes in whispering. I think you need coffee. Okay, so take this case and I will set you free, okay? But if you answer it correctly. Okay, I will scroll this. Okay, stop me when you find something. Okay. What do you see here? I think it's better to look at TV. Okay, so what do you think regarding the pattern? I think you can see here. This is on the left. You mean the left? Okay, but is it focal area? It's almost linear, multiple linear, but maybe close to each other, multiple linear. Okay, what about this? This is a linear on the right, okay? But these are multiple linear, okay? So I come down. What about here? This is focal, not focal, okay? And in the right side, normal. Almost this we not consider. This is a dominant is upright, okay? This is, don't forget the last cuts. This is prostatic neurovascular bundle. Okay, neurovascular bundle, neurovascular. Okay, so I don't see any significant lesion on T2. Okay, actually I see, but I will. If you don't see, as long as we looking for peripheral zone, so we should rely on diffusion. So let us bring diffusion. I will bring 3 layouts. Yes, this layout. Okay, this is the ADC, this is diffusion, and this is T2. This is the level of base, and this is the level of transitions. Central zone. Okay, I will scroll it. Look, central zone, the mustache sign, characteristic, and no signal, no restriction. This is normal. Okay. Okay, what do you think? There is something? Here, if there is a corresponding lesion on T2, obvious lesion? No, that is why we said that the dominant sequence of a peripheral zone is diffusion, because diffusion can detect lesions not obvious on T2. Okay, so this is a classic example of a case will not appear on the diffusion. Okay, so don't stop. If you find T2 almost normal or PIRAD 1 or 2, you are not finishing the exam. Okay, you should need to examine the diffusion carefully for such small lesion like that. And almost this is the last 2 cuts of the case. Okay, don't forget that. This is a very low ADC and very restricted p value. Okay, so it will be 4 or 5 at least. 4 or 5 at least. Okay, let's check again. What about contrast? Take. Okay, and it's positive. It's higher than the right side. Okay, so it's positive here. Okay, however, by this, I don't need for this. You understand? Okay, but this is an example of the concept of dominant sequence is very essential to apply. Okay, I think time for coffee. Okay, or we can go on. If you'd like, go on. Okay, ماشي يعني it's up to you. خلينا which the largest number will follow. Break. Oh. Okay, خلاص دكتور حسين السيد هو. Okay. لا لا اتفضل. لا. انا كتبت one name كده طبعا. اه 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 Hello. Works. نعم. نسبة الأورام هي peripheral almost 70%. البريفرال زون almost 70%. ترانزيشن زون about 25 30. وكومبايند بقى الادفانسد كيسز دي بنشوفها يمكن اكتر. في اي استفسار regarding الترانزيشن البريفرال زون؟ اوكي. طيب الترانزيشن زون كونسبتس بقى يمكن احنا اتكلمنا هنت بسيط عليها وقلنا حته موضوع الدومينانت سيكونس for transition zone is T2. Well, I think from the many cases we browse, we can understand now why. Because it's harboring many PBH nodules, and PBH nodules has no definite imaging criteria regarding, especially for contrast. So contrast has no role in the transition zone, and diffusion has a specific role. This is maybe the confusing point of transition zone, and maybe the Virad version 2. It changed to Virad version 2.1 for small modification for transition zone, not for the peripheral zone. So just modification which happened during 4 years, 2015 till 2019, just for Virad 2 of transition zone. In the old version, we can say this is Virad 2 if there is a definite PBH nodule. Okay, we reported. But in the current version, no. If you see this is a PBH nodule, don't score it. We don't score this lesion. Okay? This is an important concept. So through the 4 years after 2015, they make a lot of study and make, I shared many research articles and papers about transition zone. And finally, they produced 4 new concepts, 4 new terminology for transition zone. Typical nodule, which is PBH nodule. All of us, we know it. And we will see which is a nodule, rounded, not circumscribed, rounded nodule with definite low signal capsule. This is the typical pattern of the PBH nodule. Okay? But we found that there is a typical nodule. Okay? And there is another term, the area in between nodules. It means that in the transition zone, you might find just area, no nodule, just area between nodules. You need to characterize it. Okay? And the term background What's mean by background? Background, it means what's the dominant pattern of the transition zone. Is it all heterogeneous? Is it all PBH nodule? Is it all typical nodule? Is it all is mixed between typical and atypical nodules and so on? And finally, our concern is what's the typical pattern of cancer in transition zone. This is our concern. We shouldn't miss, because all these patterns almost normal, but there is some cases positive, we should know. So the typical pattern of the cancer, this is the first thing we shouldn't miss in transition zone. Okay, so let's see. I will start with the PIRAT 4 and PIRAT 5. This is a typical pattern. Okay. Okay, now we have a peripheral zone. If I can describe this pattern of peripheral zone, how can I describe it? Is there a focal suspicious area? In the image A, there is a suspicious focal area in the peripheral zone. Peripheral zone, suspicious focal, low signal intensity. Okay, I can say no. Maybe there is some heterogeneity here. Could be linear, yes, but there is no suspicious focal, very low, okay? So, in image B, we can say there is a diffuse low signal on the right side compared to left side. This is also not typical pattern, because this is not a focal and not very low. We have two terms, keep in mind, when you find lesion very focal and very low signal. Okay, in T2 and on ADC. On T2 and on ADC, so you should have a concern. Okay, so come back to transition zone. What the obvious abnormality you can see on the image A? Hypointense area. Here? Okay. So can we more precise in description? What do you think? This area, I think this is the usual pattern of transition, okay? You have a different signal intensity of PBH nodule. This is the normal heterogeneous, okay? So, however, this area, okay, it's, as Dr. Sami said, low, but it is not very low like ADC or something, but it obscuring, it's like a mass. Actually, I can say it is a mass. It is additional soft tissue on normal soft tissue. Okay, you feel that there is something you added on the image. When you find this pattern, this is very dangerous pattern. Okay, this is a lesion, very significant lesion. Okay. Okay, so let's check in the image B. What do you notice? On transition zone. No, another case. Yeah. They are two different cases. Yes. In the anterior aspect. Okay, but there is something. Yes. There is extension. Okay, but not extracapsular. what's the anatomical area here, which is characteristic by low, very low signal, and it is normal, and the anterior. Yes, exactly. The anterior fibromuscular stroma. And in the first lecture, we said that anterior fibromuscular stroma, it shouldn't have a de novo cancer because it has no glandular glands. Yes. However, usually, it will harboring an extension from adjacent structure, either in the transition zone, which is the most common because it's in direct contact, or even in the peripheral zone. Okay, so this is the very low background of AFS, or what we call anterior fibromuscular stroma, make this abnormal tissue is more obvious, more clear. There is something here abnormal in the image, okay? So this is another soft tissue mass, and very obvious due to its extension to the anterior fibromuscular stroma. But what if the lesion here and not extended beyond here? It will be difficult to detect. It will be difficult to detect. It's not like that. This is a very large lesion, so all of us, we can realize it. However, if this lesion, this is the trick, the difficulty of the transition zone, if you find this lesion and without no extension, yes, it's not easy, but how can overcome this problem? Okay. If you see, check these lesions. Remember this shape, this pattern. This pattern, what we call, do you know this pattern, this shape? Napoleon, Napoleon have. Yes, maybe it's similar, okay, but it's more fuzzy. No, this is wedge shape. No, it's triangular maybe, but it's called lenticular. It's like lenticular. It's like the lens. It's almost like a lens. So it's this is a descriptive term in the even in the guideline, a lenticular. So be concerned about lenticular shape of a lesion. When you find this lenticular shape of the lesion, this is the typical pattern of transition zone cancer. Okay? If you look at the image A, please look at the monitor here, not here because it's not obvious. If I would trace this lesion, it's almost lenticular, but it has a wide diameter. The AB diameter here is more wider, but it's more or less, okay, if I can shrink that, it will be a lenticular too. So this is the descriptive term for transition zone, the typical pattern when you find a lenticular area. Okay, a lenticular area, because this is a lenticular area masking the remaining background. It should expect the background of this heterogeneity extend till the margin here. But when you find this area is erased, another sign, it's called erased charcoal sign. Erased charcoal sign, it means that, you know, the charcoal, okay, when you charcoal, when we were young, make a drawing by the charcoal pen and give a cotton piece and make shadows. The area become not clear. This is the same pattern. This is called lenticular charcoal erase sign, because they mask the underlying structure, expected structure in this area. Okay, so this is area of soft tissue, masked all the expected PVH and even heterogeneity of this area. Okay, so keep this in your mind. You look for this area. You look for charcuterie sign. You look for a lenticular area, okay, of no details, just like soft tissue mass. I will remove it again. So in normal prostate, I will find this pattern extend even till here. But now it's erased. It's not here, present, okay? it's replaced by another tissue. Okay? Here, of course, it's more easy because it's larger, but the same concept. The anterior part of the prostate of transition zone here, it should be like that. It should be like this. But this background is not here, disappear. Okay? This is what we call the typical pattern or lenticular sign or a charcoal erase sign, and always remember the charcoal pen. This is actually the descriptive term which I'd like or recommend to use in your report. Lenticular or non-circumscribed homogeneous, moderately hypointense, maybe less than 1.5 or more. It will give you your pyrad, 4 or 5, the same rule. You understand? Okay? This is the measurement. We said it about before about the peripheral zone. The same rule will apply. The longest dimension to make a dimensions. So don't say, if you take, you need to know which is the longest dimension, the orange line or blue line. Okay, don't say in the report 2 dimension. This is not allowed. Okay, just for you to determine which one is the longer. For example, which one is longer here? Orange. And here? Okay, so you make this measurement, but don't mention in the report except the longest diameter. Okay? This is the same rule I answered before. What if the lesion less than 1.5? However, it has extra capsular extension, so it will be assigned for BIRAD. For which BIRAD? BIRAD 5. Okay. So this is the typical pattern which shouldn't be missed. So what are the remaining patterns? Because maybe confuse you. What about typical nodule, a typical nodule? What's it mean by area in between and background? This is the pattern of typical nodule. The center is not matter us. The center of the nodule, it doesn't matter me, ما يهمنيش, okay? Doesn't matter of the nodule. The most important factor to say it is typical nodule is complete surrounding low-lying capsular line, like this line. If you have such line encircling, completely encircling this nodule, so you are dealing with PBH nodule. And this shouldn't be scored. Okay, but it is a PIRAD 1 and no need to score. PIRAD 1, this is PBH nodule, this is the line which I described for you. This is ADC image, okay? We can find this is very low in ADC and restricted in diffusion. So maybe not very bright, but I can say it's mild restricted. So which PIRAD I assign? As if diffusion component doesn't equal. Which PIRAD I will assign? It will be assigned as 1, 2, not PIRAD 3. In peripheral zone, we say PIRAD 3, okay? But here, it will PIRAD 1, because this is a typical nodule. And remember that we are talking about the dominant sequence of transition zone, which is T2, not diffusion. So the T2 score, it has the upper hand of scoring system, not the diffusion in this case, okay? And this image indicates and shows you PBH nodule can take any pattern. restriction, no restriction, and even this is dynamic. It take early enhancement earlier than the background, which in the peripheral zone we said that it should be, say, positive. But here we not rely on it. This is why we neglect all these sequences if we can see a typical nodule. Okay? What about Pyrite 2? This is the changes which happened from the last version to the from previous version, 2 to 2.1. If you don't have a typical nodule, so you have one of these. Either nodule mostly capsulated, almost capsulated, but not as a whole, as a typical one, okay? Or a nodule without encapsulation, okay? Or there is no nodule, but there is area without nodules, area between nodules without nodules. All these assigned for Pyrite 2. Let's see example for this. What do you think about this? Is it completely capsulated? No. The high signal, low signal here is interrupted here. So it's incompletely capsulated. So it's called a typical nodule. Okay? This is a typical nodule. Which Pyrite should be Pyrite 2? Type. What about this? Do you see any low signal capsule? There is no obvious low signal. So this is non-capsulated nodule. So which assign? Which Pyrite? Pyrite 2. Okay, so what's this area? Is that nodule? No nodule. This is an area, and this is a nodule, and this is a large nodule. So this is what we call the area in between, okay? So it will assign for Pyrite 2. So this is the different traits or different patterns of Pyrite 2. If you have, so again, this is the most contributing for a transition zone. But we are talking about a different pattern of benign lesions. That's all. So you know the benign lesion and different pattern, so you shouldn't miss to interpret. Okay? This is the idea. Either have incomplete capsulation or no capsulation at all, or area between nodules. Okay? So this is a complete case. This is the just case which said incomplete capsule. But what about diffusion? This is on T2. What about their diffusion? This is one case. ADC, very low, okay? And in B diffusion, very bright. Is this a change in the score? No. Here, I can assign it as a Pyrite 4 or 5. But remember that we are talking about transition zone, not for peripheral zone. If this lesion, it's circumscribed and focal, very low in ADC, very low, very bright on diffusion, if this lesion is here, for example, I will assign for Pyrite 5 or 5. Okay? But we are here in transition zone. So the concept is different. Here, the dominant sequence is T2. Okay? So I will grade it for Pyrite 2, incomplete. I will give some exceptions for this. This is the same. This is which pattern? Area in between. Okay. Is this restricted? No restriction. So it's normal. It's Pyrite 2. Okay. Pyrite 2, okay, because it's no capsulation, but restricted. Okay. I will give here for Pyrite, which Pyrite in diffusion? No, this is, I will give the It's very low and very bright. 4, maybe 4. Okay, 4. What about the final score for such lesion? Here we say T, or here we see 2, and here we see 4. First question, first, does we need a contrast? No need a contrast, why? Okay. All of us agree about this? Yes, you should agree, because I've said many times, contrast has no role in transition zone, okay? If my only suspicious area is in transition zone, no need for contrast. Okay. So it means that I give a score of PIRAT 2 on T2, okay, and PIRAT 5 on diffusion, okay. So what's the final score? Based on the dominant sequence, I would say 2, okay. Note that. Note this is the minor exception here, and I need to understand. I will jump all this now. I will give you. Diffusion can change the score of T2 in 2 case scenarios. The first scenario here, if you have PIRAT 3, okay, diffusion can make it, if I have a lesion PIRAT 3, diffusion can still as PIRAT 3 or make it as a PIRAT 4. And I deal with the final score as a PIRAT 4. Exactly. So if the diffusion score from 1 to 4, it will be the same. It will be the same, PIRAT 3. But if it is a 5, here, the size of the lesion is more 1.5 and very low in ADC and very bright, it will be changed suspicious for 4. Not suspicious, it will be 4. Okay, and should be biopsy. Okay, this is the first scenario. The second scenario for PIRAT 2. PIRAT 2 lesion on T2 as a previous case. Okay, diffusion is 1 to 3. It will be 2. But if I say 4 or 5, it will be turned to 3. What is the next step? MDT. Say it MDT. We will discuss. Okay? So this is 2 situations which can change the scoring of the dominant sequence of transition zone. So come back to this case again. This is a T2. Okay? And this is the score. Which score? This is less than 1.5. 4. So the final score is 3. You got it? But if the diffusion is 3, it will still 2. Okay? This is very important. This is the whole problem of transition zone. If you understand this, so you have no problem with transition. And all these description, this is what I have mentioned. But if you read it, you will stuck. If you read it without explanation, you will stuck. Okay? But if you read it now, you will understand what they mean. Okay, this is another examples of PIRAT 2. This is from the manual, the Atlas manual. Give you different examples of PIRAT 2. This is area in between. I think no one doesn't agree. And this is area without capsule. So it's a pyrite 2 at the level of T2. So this diagram describes what we have said. If you see this diagram for first time, you will not understand what that means. But this is the name. This is simply. So the problem here, don't have problem in pyrite 1, don't have problem in pyrite 4 or pyrite 5. The problem is between 2 and 3 in the transition zone. So simply, I think this is why I made this diagram. It may be more simplified than 1. Okay? So if you have a pyrite 2, you need to be sure whatever the diffusion, as long as 1 to 3, okay. And simply remember it like that. If the diffusion double the scoring of the T2, you will upgrade. If not double score, you will not. So if the diffusion T2 upgraded to 4, you will upgrade. Upgrade for 3. Okay? The same. 3 to 5, you will add 2. If you add 2, okay, it will be upgraded to 4. Okay? Okay, the same as peripheral zone. You can notice that pyrite 4 and the pyrite 5. You can notice where is the lenticular air lesion. Yes, 4 and 5. This is a small lenticular lesion, but this is a small lenticular region. Here in T2 or ADC or diffusion, its value here, it will confirm the shape. Because in ADC especially make a more distinction the margin of the lesion or the suspicious area. So it confirms the shape of the lesion. It's like lenticular as we have mentioned. Okay? What's this? It's 1. Okay, typical nodule in the area in between. Okay, so what about pyrite 3 in transition zone? Pyrite 3 simply area other than 1, 2, 4, or 5. What? Yes, you cannot assign this lesion for 1, you cannot assign for 2, and you cannot assign for 4 or 5. So it will be pyrite 3. If you take it like this, you find it easy, okay? But however, there is description heterogeneous signal intensity with obscured margin. Include others. Don't qualify 2, 4, or 5. Okay? This is, for example, here. This is a not nodule. Okay? It's not area in between. It's not a typical nodule. Okay? And it's at the same time not lenticular. Lenticular usually like that, as horizontal line like that, okay? But this area actually is suspicious because it's like a soft tissue more than PBH nodule. This is the case we described. So what about diffusion? Diffusion, if you find no abnormality in the B value, no bright signals, okay, and no corresponding low signal, it's diffusion 1. However, in diffusion, PBH nodule, as I said, it may take every pattern. Okay, this is the pattern of 3. What you find here. This is ADC and this is P value. What's the difference here? Why we assign this lesion as a 3? The same rule of peripheral zone. Why we assign lesion for pyrite 3? The diffusion of peripheral zone is the same as diffusion of the peripheral zone. Why we assign the lesion for pyrite 3 in diffusion? Yes? أيوة, there is no comparable high signal. Yes, بالظبط, exactly. And even the description say markedly hyper intense on hyper intense on diffusion, and no abnormality on mild low ADC. It means that simply not the same degree of restriction. Suppose that when I say this is a very bright and a very low, I can't say this pyrite 3, I say at least pyrite 4. Is that true? Very bright and very low. You mentioned that, you notice that I mentioned very, very, marked. But here I will say minimal restriction and very low ADC. As long as the post sequence not the same, so we are dealing with pyrite 3, either in the peripheral zone or in the transition zone. Look here, again, I pyrite 3 here, but what's the difference when I say this is a pyrite 4 diffusion? What's the difference? Restriction, bright signal. This is a very bright signal and a very low signal. And in the same time, it has the lenticular pole, okay? Not as long as you say focal or markedly at both bright and ADC, it means that you are dealing with 4 or 5. One of them is obvious, significant, and the other is not, so you are dealing with pyrite. Okay? It's easy. All these diagrams you can find on the when you Google, but I think I give you the simplest way for this. So let's check some cases for transition zone. Okay, I will scroll from starting from the apex. No, I think this is no. This is here in preference. Maybe I electron number here. Okay. When you look now, we take both zones now. So I need from you to look at both zones. You may find lesions at both zones, okay? But as I'm looking for T2, and I know that T2 is the dominant for T2, so I will focus my concern will on T2, okay? You found something? Nothing? Okay, this is what, oh yeah. A lenticular form. Okay. Yes. Okay, this is the soft tissue. So let's check the diffusion pattern. So what do you think? So which is score on T2? I think it's much larger than 1.5, yes. So I will, okay, I will assign for Pirate 4, Pirate 5. Okay, what about, okay, what about the diffusion? Yes, which score? Yeah, and if you said 3, okay, it may be not comparable, but I think it's, I don't know, where is yes, maybe in the monitor, in the diffusion, has no much restriction, but actually it's restricted here on the laptop. But okay, even if it is 3 on diffusion, so which is the final score? ST2, because the T2 is the dominant sequence here. Okay? Let us check another case. So what do you think? Which zone? Which zone? Where? Where? Okay, transition zone where? This one. This is, if I trace it, you will find it lenticular. Okay, but it can easily miss because it's small. Okay, you go up. Yes, and this is the nodule which bulging in the bladder maybe. You so I think before PBH, third TRP, you make a biopsy, a routine or not?
Routine?
Hmm?
If it is very high PSA or high PSA or abnormal PSA.
And even after you didn't make any pathology for the specimen? Specimen, yeah, yeah. Okay, so what's this area? Yes. Central zone. Yes. Okay. It became very clever. Okay. So come back to what do you think about this cut? Do you have something catch your eyes? Yes, in the peripheral zone, linear. Okay, but when you see a lot of cases like that, usually okay, I'm very sure it's nothing. Okay, but I'm talking about transition zone. Do you notice anything? Yes. Okay. So Which pattern of PVH? Typical or atypical? Okay. And what's this? Where is this? This is a nodule? Yeah. And what about this? In which location, in which zone? Peripheral or transition? We have difficulty to determine, okay? No, it's not central. Central should the base. This is why we should look at the other orthogonal. Orthogonal. Here, I will check for sagittal or coronal. Okay, I will check. Here I think sagittal. Can you find the suspicious area of transition zone? That's here. And this is the nodule here. And this one is transition. Okay, I scroll every finding with you to know how we think and how to deal. Okay, so what about this? No one say about this. Yours, Dr. Sami, you say about the peripheral zone. So which score you will assign? Which score? What about this level? I will assign 4 or 5. Okay, but the interesting point here is not very low. Is not very low in signal. So it should be go to next step. So we have 2 suspicious lesions, one in the peripheral zone, one in the transition zone, and need to be confirmed. Okay, so let's check the transition zone. What do you think? Sorry, the peripheral zone. Yes. What do you think regarding diffusion and ABC? Which score you will assign? Okay. Here I will assign myself, I will assign for 2. Total score for this area 2, because this is not very low and this is almost no restriction here. Okay. So even in some reports when definite in diffusion it's pyrite 3, I cannot say it's pyrite 2, but I feel no. I can say it's pyrite 3, but in final conclusion, it is a prostatitis, no need for biopsy. Okay, so in this case, I'm tell the clinician no need for discussion. I know that it's a prostatitis. Okay, so no need for discussion. I'm sure it's prostatitis. Okay, but in some cases, when I give a sign pyrite 3 and stop for follow up or give recommendation, no, this is a case of query, really query, and we need to discuss and we need to make further investigation with it. This is an example for, yes, it could be pyrite 3, but no need, it's just prostatitis. So come back to the transition zone. This is the suspicious area here. What do you find? Yes, and no bright signal. So In diffusion, Virad? 3. It's 3. Okay. 3, and here, Virad 4 or 5. So the final score will? Yes. So we rely on T2. We rely on T2. This is cancer, okay? So what diffusion here doesn't give me, it may be confusing me, okay? But in the peripheral zone, the concept is reverse. Okay, let's check another case. So, anyone? Anyone catch anything? Hmm. DBH. Any other opinion? Right? Right, 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 which zone? Okay, يعني, is this nodule or mass or what? Or area in between? Not a nodule. Okay. Mass. Okay. If we, I will check if this is, which one here? If we look at this area, okay, if I'm tracing it like that, what you will find here? This is the characteristic shape of what? Lenticular. Yes. Every cancer try to escape from you, so you should know every pattern. Okay, this is a lenticular area here. Okay, and if you go up, it masks the other side, like should be like that. This should be like that, but there is no nodule. You can say this a large area, one erased area. This is two options. This is erased area, charcoal erased area, and if you trace it, you will find it a very large lenticular lesion. Okay, what this? What? Not so hypointense like that. This is a very dense. This is likely concretions or calcifications of the prostate. Okay. So let's go to diffusion and see what this lesion. What do you think? Very restrictive, okay? But the details of the restriction may confuse me. It is a nodule, and we said that PBH could be restricted, not restricted, with different patterns. But the discriminator here is the T2. So I will rely on T2, but this is a very marked restriction, very low in ADC and very bright. Which diffusion I will give? Which is diffusion score? It will be Pirate 5. Okay. Even if the T2 suspicious and I found, if I said this is a Pirate 3, for example, and the diffusion give me a Pirate 5, so we'll jump to Pirate 4. Final score will be Pirate 4 as the rule, okay? So this is, of course, a large lesion you shouldn't miss. Especially here, this is the most suspicious area. This is like additional soft tissue. Additional soft tissue. Okay, let's see another case. It is the same, huh? The same case, yes. Which number? I don't know if you check this one. The same case, but it's not the same. It's not the same file. So this case is repeated. So I will check for another cases. Let's check these cases. This case I don't know. So we will discover this is a limited series. It's mainly biparametric. Okay, so it's a limited series. So we will discover together if this has a lesion and which lesion, which site and which zone and so on. Okay, so I will discover now with you, and this is without endorectal coil. This is done on 3 Tesla. So let's check. So what do you think? Lenticular lesion on here? I can't, this one here? No, I can see these are nodules. Where is another? This one? Okay, what about the peripheral zone? Okay, so this is prostate. Okay, so is the exam finished? Not yet. I will go to diffusion to check if there is any missing area. Okay. Do you check anything? What's this? This is almost the same level here on P2. When I see case like that, this is a very restricted lesion, okay? Very low and very high. The first question, where is the lesion is? Transition, we say transition zone. If there is transition zone, so I will check on T2, this is a PDH nodule. Okay, forget it, okay? But if it is in the peripheral zone, I cannot forget it, even if there is nothing on T2, okay? This is one of how to deal with this case. I can't find something wrong about this case, so we'll check for another case. There is something wrong in this case. You are experts now, so I browse with you some difficult cases, okay? Challenging cases. So do you think any abnormality of this case? So I will give you the whole study to make a judgment. So synchronized with each other. So what do you think? On T2, very low. Can you say which zone? Can you say which zone? Which zone? What? Transition zone? No, I don't have. These are just three, just three series. That's why challenging. But actually, it's a very easy case. Hmm? Huh? It's what? Very dark. Why it's very dark? Okay, let's see T again. Scroll with you. What this level, apex, and what this is the bright signal here. This is the last area of peripheral zone. Okay, so let us go up. This is should be a peripheral zone. Okay, this is the anatomical, and this is peripheral zone, and in the center should be transition zone start. That true? What you notice here? You cannot discriminate between the transition and peripheral zone. All the prostate is one signal, diffuse. This is a diffuse cancer. Diffuse cancer, yes. Include post loops. Well done, and I heard you, okay. Okay, at the same time, you can note that is there is extra prostatic extension?
Right.
Note this is the seminal vesicle on the left side, and this is on the right. The seminal vesicle is already infiltrated. Yes, okay, and come down here. You can note that what this area. Yes, this is what we call the rectoprostatic angle. The fat here is obliterated. So this is a diffuse prostate. This is, I cannot say which zone. It's involved in the whole zones. Okay, so this is advanced cancer, and diffusion the same. Diffusion, even I try to minimize the restriction by I can. Oh, all this restricted. All the area of the prostate was restricted. And on the ADC, even all the prostate was low. Okay, all this is low. All this low. All this low. Till here. This is the maybe normal and even normal here, but there is a restriction here. This is of the extension. So this is a diffuse cancer. Okay, advanced cancer involving the pulse areas. Okay, here I should search for lymph nodes, any bone mets. Okay, yes, bone mets, yes. Okay, so this is a tricky case. Don't say, don't imagine that the cancer will respect. I give you many cases, but the cancer doesn't respect the zones. It could be with any pattern, okay? Yeah, diffusion, yes, is the same. It checks. You know, where? Do you have any suspicious regarding this level? Right side at which zone? Here we can see prostate. Here we can see two distinct zones of prostate, huh? Okay. Peripheral here. Okay, so I don't know this is positive or negative, but we'll see. But that's right. You will report it at the level of T2. This is abnormality, and you will give, which score you will give? It's almost a wedge shape. Here? No, but remember the signal pattern. It's not very low. It's not low. It's intermediate signal. This is important, okay? You can say it looks like the transition zone, okay? So it's intermediate signal pattern and the wedge shape. So I will assign for Pyrite 2. To me, I will assign for Pyrite 2. But we'll check. Okay. Let's go down and see if there is something else. So what do you think? This area is suspicious to me because even in the left side there is a bright normal signal, but this area is suspicious to me. Okay, so what I need to do is to check in the diffusion. Okay. So what do you think? I will. What do you think? Transition actually is heterogeneous, but there is a specific area which is have a characteristic pattern on the diffusion. Can you remark this horseshoe-like pattern? This is the last few millimeter from the apex. No, it's peripheral zone. Okay. Last end of the apex. Okay. And if you correspond, this is very low. Okay. And this is a very bright. So that's why always look for the apex and start from the apex to the base. Yes, it doesn't will affect the change. Well, it doesn't will affect the signal. Okay. Here, no problem. Okay. But here, at this level, I still have suspicious. I need to check here for diffusion. But the diffusion is Pyrite 3. Unfortunately, the case should be synchronized with each other to know the level here. Here, I have a suspicious here. This is a restriction, bright restriction here, and the low ADC. This is the same level here. Okay, this area involves also the both zones. The central zone, however, it mainly affects the peripheral zone. Okay, so This is also one of the difficult cases. When you scroll the cases, try to make it synchronized like that, not like this, but like other cases. Okay, these cases have some problems to move together. Okay, we almost finished now. I will give you some another challenging cases, if you like. Just to show you, it's not, if you know, you need to see a lot of cases, yes, but at least if I rise this, make this threshold of suspicions is low for you, it's good, okay? This case is difficult because it has a motion artifact. This is the example, or I should decide to repeat the exam. This is what we call should have a pi quality score 1. It should be repeated because there is what we see now. This is a motion artifact, and the whole prostate zone, especially the transition zone, is degraded. Okay, so I cannot rely on this. I will check if this can maybe repeat the sequence. In recent scanners, there is some sequence try to minimize these artifacts. Don't know, Husseini, you know? Yes, maybe differ from vendor to vendor. Okay, let's go. What your notes? What about this area? Central zone, yes. This case reported as a large cancer in the central zone. And however, it is the central zone. So it's good to know that. Remember, this is the symmetrical pattern of ADC, symmetrical, as long as symmetrical. So this is the normal, and the mild restriction or no restriction on the ADC map. So let's check for another part of the prostate. Can we check this area, this nodule? Okay. Is it typical or atypical? Atypical, okay. So we check for diffusion. Which grade? Diffusion 4. So what's the final score? No. 3. If you say 2 and diffusion more than 2 the score, so you will another one. Okay? So it will be BIRAT 3. Okay? So let's check. What's this? Yeah. So it's a pitfall. So I'll go down. I hear there is some low linear signal intensity. There is no restriction. So it's prostatitis. Okay. I will go down farther. Okay. Anyone notes anything? Anyone? Which one? Where? This in central zone? You said central zone. This is transitional zone? Transition zone is finished. Look here. We are at the apex level. Peripheral zone, is it low in ADC? Okay, this is one of the missed cases, okay? This is not diagnosed just prostatitis, such Pirates 3 for the, okay? However, this lesion is missed, okay? In T2, there is no suspicious. In T2, there is no suspicions. However, here, we can definitely say there is a Pirate 4 or Pirate 5, according to the size. So, on T2, he may be, I will take suspicious, okay, suspicion here, but here it's definitely, and even this area as a whole on diffusion, we can see this is much bigger than T2, okay? So this is also one of the missing cases and challenging, okay? Be precise about this area. These are one of the overlooked area to be missed. Another overlooked area I'd like to highlight before we finish, remember this pattern. Remember this to the area of contact between transition and peripheral zone. This area, okay? This one and this one maybe come in contact with a low signal nodule, and you can miss it as a cancer, okay? So I think this is here. This is the corresponding site for diffusion. However, in diffusion, indicate that this is a larger. So I will measure which sequence I will measure the lesion, on T2 or on diffusion. On diffusion, okay? Okay. So, do you have any questions? It's become much easier or become more difficult?
Much easier.
Okay. The idea is to look for the areas, I call it hidden areas or overlooked area, and give the standard in your mind, and finally you will discover the missed cases, okay? Thank you, and if anyone needs questions, I'm happy to answer.
Thank you, Dr. Haitham.
You're
Thank you for completing course. We commend on your hard work and dedication, and our honor to present you with a certificate. I will start the certificate with our great speaker, Dr. Haitham. Please.
Oh. Okay, thank you. Thank you. Thank you. Okay, I will take the jacket, okay? طالما فيها. طب كنا يعني خلينا للناس الأول عشان
No, we will start with you. We are going ahead, inshallah.